It is November 13th, 2025 at 9 a.m. The board meeting of the Oregon State Board of Nursing is now called to order. A notice of this board meeting was published by Rachel Prusak, Executive Director, in accordance with the open meeting law. If necessary, the board may also meet in executive session as authorized by ORS 192.6601, ORS 192.6602 F and L, ORS 678.126, ORS 676.165, and ORS 676.1751. Board members and staff stating that they are present are attesting to understanding the confidentiality of executive session and have taken steps to ensure that the executive session proceedings are not observed or heard by anyone not authorized by Public Meetings Law 192.660. Is there a roll call by our secretary?
Yes. Marcus Cooksey.
Present.
Margaret Hill.
Present.
Claire McKinley Yoder present. Joni Callis.
Here.
Linda Stanich.
Here.
Oleniki Tuobola.
Here.
Rachel Dennis.
Here.
Philippa Nesta.
Here.
Rachel Mitzel.
Here.
There being a quorum present, I declare this board eligible to conduct its business.
Good morning.
Staff Yoder, please.
Good morning. We'll start with roll call with staff in the audience, starting with licensing manager Philip Fox, John Etherton, Barb Poultry, Amanda Meeson, Lena Redbird, Nico Van Winkle. Thank you. And Phil. Thank you. We can move over to our policy analyst.
Dr. Sarah Wickenhagen, present. Laura Blackhurst, present. Michelle Bell, present. Gretchen Cook, present.
Moving over to
Erin Ferris, present. Lauren Rauk, present. Brandy Ritter, present.
Kimberly Goddard, present. I'll just note Michelle Bell is joining us this morning. She's our newest policy analyst and is serving in the role overseeing our CNA education and filling in for our former Barbara Zhu. Welcome, Michelle. Thank you.
Great, thank you. The first thing I'd like to review is our meeting agenda for the day. And the only rearrangements I had was some of the items from the consent agenda. There was a request to discuss APRN clinical placements as well as the PhD decline. And we were thinking we would put those together when Dr. Wickenhagen is speaking in the afternoon around 1:30. So we can hold our thoughts for that. Was there anything else from the consent agenda that folks wanted to discuss?
Yes. I'd like to discuss the survey for CNAs. Let me go to it. Just had some questions.
That's it. Page 17, right? The CNA Medication Aid Annual Survey.
Yes. Basically, I was just curious after kind of reviewing this survey. I was particularly looking at like barriers that prevent students from completing programs, students' interest in healthcare, nurse assistant fields. And I really wanted to understand from this survey too, like, I know that CNAs and medical assistants are kind of competing for a lot of the same jobs. And is there anywhere in the survey that reflects that? What makes students choose a career as a medical assistant versus a career as a CNA?
I love that question. I love that question. And actually, I just have had the opportunity to go on my very first site survey along with Laura to Tillamook Bay. And they offer both an NA and a medical assistant program. And it was a question I asked them because I'm similarly curious. I don't have an answer. I think step one is to do a thorough assessment of the state and really understand what programs are out there for medical assistant. It's not really under my purview, but where that's intersecting with CNAs I do think we need to have a better understanding of that. As far as the survey that's in our packet today, looking forward, I do think we have an opportunity to make sure that the data we're collecting is the data that we need to drive the decisions here at the board. So I appreciate any input in that space.
If you're conducting a survey, I think it would be interesting to include just earning potential between the two and then scope. Because it seems like medical assistants pretty much have a broader scope and less regulation. So I would be curious what was attracting like our potential students.
I agree. And I do think there are a lot of conversations happening about that very situation and both in the community and within the board. And so I think we'll, in the future, coming meetings, I think we'll have the opportunity to dive deeper into that space. And I look forward to it.
Yeah, I'll just add really quickly that it's kind of some of the stuff that we're talking about right now, just like what does the future look like? Where can we start focusing and learning more, and what data helps drive that is part of that. And of course, this is part of that conversation. So we're thinking about what that will look like in 2026.
Thank you. Was there, the board members have anything else from the consent agenda we wanted to discuss? Sounds good. Seeing that we're good to move on. And then, so the next item would be a motion for approval of board meeting minutes. Oh, sorry, approval of the actual consent agenda. First.
Make it or do you?
I move that the consent agenda items be approved as modified.
So moved.
Second.
It's been moved and seconded. Marcus Cooksey,
Aye.
Margaret Hill,
Aye.
Claire McKinley Yoder, aye. Joni Callis,
Aye.
Linda Stanich,
Aye.
Oleniki Toabola,
Aye.
Rachel Dennis,
Aye.
Felipe Nesta,
Aye.
Rachel Mitzel.
Aye.
The motion is passed.
Then moving on to the meeting minutes from our September 16th, 17th, and 18th board retreat and meetings. Did anyone have any corrections or anything from the minutes? Looks like we're set for a motion then.
I move that the board meeting minutes be approved as presented.
So moved.
Second.
It's been moved and seconded. Marcus Cooksey,
Aye.
Margaret Hill,
Aye.
Claire McKinley Yoder, aye. Joni Callis,
Aye.
Linda Stanich,
Aye.
Oleniki Toabola,
Aye.
Rachel Dennis,
Aye.
Felipe Nesta,
Aye.
Rachel Mitzel.
Aye.
The motion is passed.
So now we'll move on. We have a lot of administrative rulemaking to address this morning. Looks like our first item is on page 57 related to Division 1, and Dr. Wickenhagen will speak to these two.
Good morning. Mr. President, members of the board, here we are. I would like for your consideration today these rules proposed for permanent adoption. Together, these divisions represent the board's continued work under House Bill 3044, which directed modernization and consolidation of the Nurse Practice Act, streamlining licensure rules while preserving public protection. Starting with Divisions 1 and 2, these contain general housekeeping edits to ensure consistency across all board rules. The changes clarify definitions, update rule numbering and cross-references, and align board processes with current administrative practice. For example, several cross-references were corrected to reflect the new Division 31 numbering, and outdated references to repealed sections were removed. No substantive changes were made that alter license requirements or board authority. There were no public comments received on Division 1 or 2, and staff recommend these rules be adopted as presented.
Were there any questions or discussion related to Division 1 or 2? No? It looks like we're ready for the motions.
For both 1 and 2 or just 1?
I think 1 and 2.
You could do Division 1.
Let's start with Division 1. Let's start with Division 1 then, and then we'll give a moment for the board.
I would like to propose that the board approve the permanent adoption of the proposed amendments to OAR Chapter 851, Division 001, Rule numbers 009, 0015, 0100, 0111, 0115, 0122, and 0170, as presented effective January 1st, 2026.
So moved.
Second. It's been moved and seconded. Marcus Cooksey,
Aye.
Margaret Hill,
Aye.
Claire McKinley Yoder, aye. Joni Kellis.
No.
Linda Stanich,
Aye.
Oleniki Toabola,
Aye.
Rachel Dennis,
Aye.
Philippa Nesta,
Aye.
Rachel Mitzel.
Aye.
The motion is passed.
In regards to Division 2, would you like to have a discussion?
No, I scrolled through my notes. I didn't make any comments on this one.
Yeah.
I had circled clarified language, fees are not refundable at board discretion. And then they are refundable. Okay, so just the wording of that had confused me. Thank you.
Absolutely. You ready for a motion?
I think so.
Okay. I would like to propose that the board approve the permanent adoption of the proposed amendments to OAR Chapter 851, Division 002, Rule numbers 000, 0010, 0020, 0030, 0035, 0040, 0050, as presented effective January 1st, 2026.
So moved.
Second. It's been moved and seconded. Marcus Cooksey,
Aye.
Margaret Hill,
Aye.
Claire McKinley Yoder, aye. Joni Kellis.
Aye.
Linda Stanich.
Aye.
Oleniki Toabola,
Aye.
Rachel Dennis,
Aye.
Philippa Nesta,
Aye.
Rachel Mitzel.
Aye.
The motion is passed.
We followed by my colleague Gretchen Cook.
I do have some questions on this one. On page 102, under advanced practice registered nurses, APRNs. I was just noticing that midwife is not included.
I can address that question.
Okay.
So when we. Right there,
Mike's
issue with Mike. Okay, this is Dr. Sarah Wickenhagen. I'd like to address that question of Board Member Witzel. So Mitzel, sorry, I apologize. Looks like a W from here. I would love to talk about this topic because this has been something I've been concerned about for a number of years in this position. But originally, when we started licensing advanced practice nurses in the state, we weren't part of the consensus model. And so we had nurse practitioners and we had CRNAs and then we had CNSs. And so midwives themselves were tucked under nurse practitioners. And in most other states in the country, they have a specific role as a CNM, not necessarily the same scope of practice as a nurse practitioner. But since we've had those recognized in the state and been under the regulation of the Board of Nursing, they've been under the title Nurse Practitioner CNM.
I feel like, and correct me if I'm wrong, I thought that they were included as an APRN and not a nurse practitioner.
So
in
unfortunately,
Oregon.
that's not the case in Oregon. So by statute, we do the definition of CNM, and they are not part of the APRN title protection. In the future, I am more than engaged to change statute potentially.
So they're not considered advanced practice nurses.
So they are, but
They
maybe we
are.
should turn to
I'm
Chief
just
Staff
trying,
Goddard.
Yeah.
I mean, because I feel like that they were part of the language and I was like, what? Where'd they go?
So to follow up, it's a statutory, it would require, a statutory change in order to identify them as something other than NP, like as their own grouping.
Yeah.
This would have to go back to the legislature and require a statutory change.
But they are considered APRNs.
They
They're
are.
just not one of
They're
the
just not
three
their own.
subcategory here.
Exactly.
So just clarifying, so my understanding is correct. What you're saying is that nurse practitioner is a broad scope and then APRN is a more selective scope? Because my understanding was the opposite of that.
Let me clarify.
Okay.
So advanced practice nurses traditionally in the rest of the country have 4 distinct models: certified nurse practitioner, CRNA, CNS, and CNM. We don't do that in Oregon because of our statute. Our statute only recognizes nurse practitioners, CNSs, and CRNAs. And because of that, and because we respect CNMs and we want them to have practice authority and admitting privileges and be a part of a regulated profession and for public safety, they're considered nurse practitioners.
This has been a conversation. I'll just add that this has been a conversation in the legislature for quite some time, and you see it show up and then it kind of goes away and there's, it falls off. But it is a continuing conversation there.
Yeah, I know I'm licensed in Washington, but Washington considers everybody an APRN. And then they don't kind of distinguish out nurse practitioner versus APRN.
We have some unique statutory
Sounds like it.
framework.
And if I could clarify too, there's obviously some politics involved in that. So every time we open up statute, there's an opportunity to limit what is in statute. And so the concern in the past has been, if we open up statute and potentially have this rule, could that affect them at a detriment?
Okay. The second question I have, if nobody else has questions on 16, delegation process.
Okay.
And it says means the process used by an RN in a community-based setting to delegate the performance of a plan of care of nursing. Is that also to encompass like APRNs and NPs too, in the delegation process? Because APRNs and NPs delegate, but it only is at the RN level. So
Well, it's based on the definition. So that practice authority that's described in definitions as delegation process is attached to the registered nurse license. And that's based on ORS 678150, where it provides that the board shall prescribe rules that the RN may delegate in specific settings. So that's what that is tied to. And I'm not sure if what you're talking to is just kind of about a Webster's version of the term delegate. Nurses usually frequently use that interchangeably with assign, which in common nomenclature is acceptable. However, based on the laws and rules of the Practice Act, they have distinct meanings. If an APRN chooses to use delegation process, they would be doing that under their RN license in a community-based setting specific to a client and an unregulated assistant person.
okay, thank you. That answers my question.
Okay. Any other questions or discussions
I
concerning?
think we
Proposed?
I do have a question. And so this is to educate me. We've defined licensee, and it doesn't include the APRNs. So when we were doing all that language with licensees and certificate holders, in another when we opened up another division and we had all that licensee and certificate holder language, was that foreseen that APRNs were not part of that definition?
Not sure I understand the
You-
question.
Look at number 27.
Is that the?
That's
Licensee?
what,
The reference?
yes, that's
'Cause
what raised the question.
It says
for me.
nurse practitioner, clinical nurse specialist, CRNA. It has that included.
Yeah.
Okay.
Maybe because it's on the next page.
It is.
I might assist Member Hill if you don't mind. I think it's because it doesn't distinctively say APRN as opposed to calling out the specific types of
Okay, okay.
APRN.
thank you.
you.
But they're all there,
But they're all
all
there. Okay, so this is sort of the same.
including the nurse intern.
Yes,
Okay,
as a license holder.
thank you.
Yeah. Yeah. Any additional questions or discussions? Okay. So with that, there were no public comments received on the proposed definitions put forward in this division. And staff recommend that these proposed amendments be adopted as presented.
So move. Yeah, let's do it.
So well, first motion, let me read
All
the
right.
I was just gonna.
Full motion.
Right.
All right.
So for Division 6, it is moved that the board approve the permanent adoption of rule number 851-006-0011 as presented, effective January 1, 2026.
So moved.
Second,
It's been moved and seconded. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toabola.
aye.
Rachel Dennis.
Aye.
Philippa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion is passed.
Thank you. And we have a second motion on these rules. It is moved that the board approve the permanent repeal of OAR 851-006, rule number 0010, 0020, 0030, rule number 40, 50, 60, 80, 90, 120, 130, 140, 150, 160, 180, 190, 200, and 210 as presented, effective January 1, 2026.
So moved.
Second,
Been moved and seconded. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toabola.
aye.
Rachel Dennis.
Aye.
Philippa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion is passed.
Thank you. And I will pass it off to Policy Analyst Blackhurst.
All right. Good morning, Mr. President, members of the board. Next is Division 21. So the proposed amendments in this division focused on updating terminology in alignment with House Bill 3044, replacing the term licensed independent practitioner where it was used in context of APRN preceptors and the LPN curriculum. There were no public comments received on Division 21, and staff recommend that these rules be adopted as presented. Any questions?
Looks like not. Looks like we're ready for the motion. Thank you.
Then I motion that the board approves the permanent adoption of the proposed amendments to OAR 851-021, 0045, and 0050 as presented effective January 1, 2026.
So moved.
Second,
Been moved and seconded. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toabola.
aye.
Rachel Dennis.
Aye.
Philippa Nesta.
Aye.
Rachel Mitzel. The motion passes.
Okay, I'll pass it back to Dr. Wickenhagen.
All right, next are divisions 31 and 53, which together represent a major structural element of House Bill 3044 initiative, consolidating all APRN licensure provisions into Division 31 and repealing Division 53 once the content has been integrated. Division 31 now serves as a single comprehensive source for nurse licensure, standards for LPN, RN, and APRN, while Division 53 has been retired to eliminate redundancy. I'd like to draw your attention to a few modifications to language included in your board packet. During final review, staff identified a cut and paste error in Division 31 related to APRN educational requirements, specifically the reference to the 3 Ps, advanced physiology, pharmacology, and physical assessment, and to national certification parameters. This language is standard, longstanding content from Division 53, and it was always intended to carry forward unchanged into 31 as part of the consolidation. The amendments correct the clerical omission. The corrected text appears highlighted in yellow in your packet for transparency. Additionally, we have one final edit that did not make it into the board packet. I'm having trouble with what page number it's on. This copy. It is section rule number 008, section 3C and D. These lines include dates that are past current practice, and any advanced practice nurse that meets that criteria could also be reviewed under the board rule for exceptions. The dates are more likely to cause confusion rather than clarity. We would propose that it should read, starting at 3C, all Oregon NP, CNS, and CRNA applicants must provide primary source evidence of national certification. And on line D, clinical nurse specialists without current national certification must complete 75 hours within 5 years. So that particular rule will be as modified when I present the motion.
Could you repeat the rule? Like what part that was a little?
Yeah, it's rule number 0008, section 3, letters C and D. Thank you.
This is the addendum language, correct?
It actually is not. This is an additional edit that didn't make it into the addendum pack.
But on the addendum language?
Yes.
Thank you.
That's in the,
You can look at the addendum. That's probably the easiest. But after further analysis and then looking back historically into our rules, these dates didn't necessarily align. And so after consulting with the policy analyst team and current practice for advanced practice registered nurses throughout the country is national certification. The only carve out that we've had in the past really has been the clinical nurse specialists. So by removing those dates, we want to not have confusion. We want to just say these 3 types of people need to be nationally certified. CNSs do not, and instead they need to do the 75 hours. We're hoping that provides clarity and not confusion.
I have a comment on the 3 Ps. Do you think that it should say across the lifespan, since that is what is the standard? That's the standard.
I think that all 3 Ps are across the lifespan because all advanced practice registered nurse programs that we approve are accredited by CCNE and by ASIN or by COA, and they all have those same requirements. So it'd be, to say it in the rules would be redundant.
I just know that if that isn't included in like the transcripts, you can't sit for for certification. And so, and I thought that not all programs in Oregon had to be accredited.
All programs at the APRN level in Oregon have to be accredited and are currently accredited.
So I actually had a question about something that was a public comment. Is that?
Oh, I was going to get to the public
Okay.
comments, if that's okay.
Yep.
Are we ready to go there?
I think so. Yeah.
In regards to public comments, the board received 4 written comments in total. 3 expressed support for the proposed changes coming from the Oregon Nurses Association, the Dean of the University of Portland School of Nursing, and a nurse practitioner licensee. All 3 recognized the board's progress in aligning education and licensure standards, supporting the continued move towards continuing education-based competency, maintenance as practical and flexible model that supports lifelong learning. We received 1 comment outside of the scope of the HB 3044 initiative. It requests the board consider adding language stating that APRN scope of practice rules supersede RN scope of practice rules. I want to clarify that APRNs are required to comply with both Division 45 and Division 55. Division 55 expands upon but does not replace RN practice authority. Maintaining compliance with both ensures accountability at all levels of licensure and protects the public. All supportive comments were acknowledged and suggestions were reviewed to ensure continued clarity between educational and licensure standards. With those clarifications and the amendments noted, staff recommend the permanent adoption of House Bill permanent adoption of Division 31 and the repeal of 53, completing the APRN licensure consolidation by House Bill 3044. This consolidation strengthens regulatory consistency, eliminates duplication, and provides a single transparent source of APRN licensure requirements.
I'm just, just trying to scroll to my notes, but I had a question on it. Getting to it.
Board Member Dennis.
Okay, so, I don't know if maybe it was just something like a little, mix up, but there's a comment from Brooke Bliss that's talking about LPNs. Is that the one you're saying that it's exceeding the scope?
So I'm going to address that in 62,
Okay,
if that's okay.
yeah, I was included here too, so I wasn't sure.
So my comments or questions are based on the two letters that were received, one by Urana and the second one by Christine Mendoza Ruvalcaba, regarding, let's see, I think it's on page 285, 851 550010, number 1. Where it says that it's related to the practice of the registered nurse are applicable to the APRN. And I'm wondering if the concern really is that there is because the roles are so different, that there maybe could be like a little bit more of a carve out in the language. Let's see.
I'm sorry, Board Member Mitchell, can you tell me what page you're on?
I'm on 285.
Thank you.
Yep. And there was a couple of suggestions that they had put in these letters that I was wondering why they didn't seem like really that big of asks. So I just wondered why you chose not to include them. One for the first one from Christine Mendoza Ruvalcaba, I don't know. Thank you. She was suggesting that including healthcare policy and development, implementation and evaluation in that would be beneficial. And I thought I actually agreed with her that there wasn't a real carve out for that. And then the second one is for the Urana suggestion that it changed to, that's 851-045, to the scope and standards for a specific role and population focus of APRN supersede the scope of the standards of an RN where conflict between scope and standards exist, if any. I thought that was more clarifying to kind of differentiate those two roles.
Can we maybe have that conversation when we get to Division 45 and 55 and, right?
Sure.
I just want to best connect it to the divisions that we're on, just for clarity.
Sure.
Yeah, so we were talking about Division 31 and some modifications. There were 2 modifications that Dr. Wickenhagen had mentioned.
Are we ready for a motion?
I think so. Doesn't look, since we were talking about other things, probably, I think we're done with 31. Yes. Ready.
I would like to propose the board approve permanent adoption of OAR Chapter 851, Division 31, Rule Number 0008 and 0042 as modified, effective January 1st, 2026.
So moved.
Second. Been moved and seconded. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder, aye. Joni Callis.
No.
Linda Stanich.
Aye.
Oleniki Toabola.
Aye.
Rachel Dennis.
Aye.
Philippa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion is passed.
I have a few more motions. The board approve the permanent adoption of the proposed amendments to OAR Chapter 851, Division 31, Rule Numbers 006, 0035, 0039, 0041, 0048, 0051, 0052, 0055, 0085, 0086, and 0087 as presented, effective January 1st, 2026.
So moved.
Second. Been moved and seconded. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder, aye. Joni Callis.
No.
Linda Stanich.
Aye.
Oleniki Toabola.
Aye.
Rachel Dennis.
Aye.
Philippa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion is passed.
It looks like I did make a little error here. I thought I was being sneaky by adding in 08 and 042 as modified. But as I turn the page, I see I left out 43. So I have to do a motion for just one specific rule as modified. So I apologize. The board approves the permanent adoption of OAR Chapter 851, Division 31, Rule Number 0043 as modified, effective January 1st, 2026.
So moved.
Second. It's been moved and seconded. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder, aye. Joni Callis.
No.
Linda Stanich.
Aye.
Oleniki Toabola.
Aye.
Rachel Dennis.
Aye.
Philippa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion is passed.
Okay. The board approves the permanent repeal of OAR Chapter 851, Division 31, Rule Number 0015, 0021, 0026, 0027, 0032, 0040, and 0061 as presented, effective January 1st, 2026.
So moved.
Second. Been moved and seconded. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder, aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toabola.
Aye.
Rachel Dennis.
Aye.
Philippa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion is passed.
I also have a motion in regards to the repeal of Division 53, as obviously that is necessary if we proceed with the changes in Division 31. The board approves the permanent repeal of OAR Chapter 851 and Division 53 as presented, effective January 1st, 2026.
So moved.
Second. Been moved and seconded. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder, aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toabola.
Aye.
Rachel Dennis.
Aye.
Philippa Nesta.
Aye. Sorry.
No worries. Rachel Mitzel. The motion is passed.
I will be followed by policy analyst Laura Blackhurst.
Okay, hello again, Mr. President, members of the board. Next are the proposed amendments to Division 41. The bulk of these revisions are related to House Bill 3044 changes. These are impacting the processes for the nurse intern license, the application, as well as clarifying the intern's supervision as a role, their role as a member of the practice team. There are additional amendments to this division to align terminology with Divisions 6 and 21 of the Practice Act, and revisions that provide updates on the statutory citations on the rules to reflect our current statutes. There were no public comments received on Division 41, and again, staff recommend that these rules be adopted as presented. Any questions?
Okay, looks like we're ready for the motion.
All right, I have two motions for this one. So I motion the board approves the permanent adoption of the proposed amendments to OAR 851-041, 0000, 0010, 0020, and 0040 as presented, effective January 1, 2026.
So moved.
Second.
Been moved and seconded. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder, aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Tuabola.
Aye.
Rachel Dennis.
Aye.
Felipa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion is passed.
And then I motion the board approves the permanent repeal of OAR 851-041, 0030 as presented, effective January 1, 2026.
So moved.
Second.
Been moved and seconded. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder, aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Tuabola.
Aye.
Rachel Dennis.
Aye.
Felipa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion is passed.
Great, I will pass it back to Policy Analyst Cook.
Thank you very much. Next up, it's agenda item AR8, and these are the proposed revisions to Division 45, Scope and Standards of Practice for the LPN and the RN. The proposed amendments align Division 45 with the requirements of House Bill 3044 and make grammatical revisions to accommodate those requirements. The proposed amendments also permit or now add clinical direction of LPN practice to occur by the Physician Associates Treatment Plan. No public comments were received on Division 45. I did want to note out that I have one modification that was caught, and that one is found on page 238 of your packet. And it's concerning rule number 0050 on LPN scope and the practice of nursing. And when you get to page 238, it's kind of on the lower half, and it's related to sub C, number 5II, and therein you will find the word if, and it needs to be replaced with the word is, and it's regarding to direction by the plan of care. Great. So with that, I'd like to proceed with the motion. And that would be that the board approve the permanent adoption of proposed amendments to OAR 851-045, 0050, 0060, 0062, 63, 65, and 0070 as modified effective January 1, 2026.
So moved.
Second.
Been moved and seconded. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder, aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Tuabola.
Aye.
Rachel Dennis.
Aye.
Felipa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion is passed.
Thank you. So next up are proposed amendments to Division 49, which is the division on related to protocol utilization and development. These proposed amendments also align the rules with the requirements of House Bill 3044 and correct current Oregon Administrative Rule citations used within the rules. No public comments were received on Division 49, and staff recommend they be adopted. So if there's no questions, I can present a motion.
Please do.
So the board, a motion that the board approve the permanent adoption of proposed amendments to OAR 851-049, 0000, 0005, 0015, and 0020 as presented effective January 1, 2026.
So moved.
Second.
It's been moved and seconded. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder, aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Tuabola.
Aye.
Rachel Dennis.
Aye.
Felipa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion is passed.
Thank you.
Board President Cooksey, could we take a 5-minute break? 10,
I was gonna say just 5.
10-minute break.
Let's meet back at 9:55. All right, so we are on the Division 55 section of our agenda this morning. So I'll let Dr. Wickenhagen start with the presentation of that, and then we can pivot to some of the questions and stuff.
Thank you, Mr. President. Moving on to Division 55, these rules define the scope of practice for APRNs. The updates here are primarily editorial, modernizing language, clarifying definitions, and aligning with terminology used through Division 31 and 45. Public comment on Division 55 focused mainly on ensuring that advanced practice standards remain clear and the alignment with RN rules does not create conflict. As I mentioned earlier, Division 55 functions as an expansion of RN scope rather than a replacement, and these revisions continue to uphold that structure. These refinements help APRNs, educators, and employers interpret the rules consistently, promoting both safe and efficient practice. No further substantive changes are proposed at this stage, and staff recommend permanent adoption.
And earlier, Board Member Mitzel had brought up one of the public comments and a suggestion from that. And I wanted to turn to Chief of Staff Goddard to give us a little context about these suggestions as well as the Division 55 changes.
Right. I think that Policy Analyst Wickenhagen is going to address some of the testimony that we received. I would say that the testimony or the suggestions are outside of the scope of the work that we're doing. And so they've been noted, and we're going to be, moving forward in next year, looking at them, seeing what they involve, and, bringing it back to this board to be talking about.
Outside of the scope.
Yeah, 3044 was specifically limited in addressing certain changes to our statute. So I don't have them right for me. Give me 1 second. The language itself or the suggestion itself is outside of the scope of the work that we're doing in the changes with House Bill 3044.
So for instance, Member Mitzel, if I may, typically if we're going to make significant or substantive changes to a division that's outside of statute, well, we would never do it outside of statute. Let me back up there. But changes we'd bring a RAC together, and we would bring several voices in, stakeholders, partners, before we would just change something so significant as what the scope of practice of someone is. And all of these changes, no scope, no board authority, none of that was done in any of these divisions. And so when we say it's out of the scope of the work that we're currently doing, that's what we're trying to put across.
I understand that. I guess I just didn't understand how it was considered outside of the scope. Because you do go into some definitions of like the APRN and their roles. So I didn't understand why healthcare policy development and implementation and evaluation was outside of the scope regarding that. And then also,
Board Member Mitzel, can I clarify what piece of the suggestion that was either in the public testimony or something that you've identified? What was the specific issue? You earlier spoke to
number 6 on page 286 says APRN scope of practice includes teaching, research, coaching, mentoring, and providing leadership using professional standards of APRN practice. I didn't understand why I guess I'm missing how healthcare policy development and implementation is outside of that scope if you're listing them out.
So we encounter this problem a lot, Board Member Mitzel, that this is a working, living document, and we can't list every possible task, procedure, potential sidetrack that any advanced practice registered nurse does. For instance, we don't mention ketamine while we know that that's a medication that's administered. So there's several different times when we are very general in our language. I am not saying that health policy, certainly as the policy analyst of the State Board of Nursing, is out of my APRN scope. I'm saying it's out of the scope of the work that we did. I am willing to take that further when we do more edits and more updates to the language and potentially make some statute changes that perhaps incorporate CNMs and fix all of those at that time. But this is within the power of the board and you can direct me otherwise, but I just want to try to explain. We're saying scope in different ways.
Board Member Mitchell. So in that particular rule, as an example, the only thing that was changed was the sub B under sub 4, under diagnosing. And that's because in House Bill 3044, diagnosing was actually addressed. So the scope of the work in this particular case results in just that one particular word being updated and that one particular section being changed. To go into some of the other subsections would be beyond the scope of 3044 and the direction from the legislature.
Okay, thank you.
Are there any other questions or observations about Division 55 before we move to motion? Okay, looks like we're ready for that motion.
I would like to propose that the board approves the permanent adoption of proposed amendments to OAR Chapter 851, Division 55, Rule numbers 000, 0010, 0020, 0030, 0040, 0050, 0070, 0072, 0076, 0080, and 0090 as presented effective January 1st, 2026. So moved.
Second.
Been moved and seconded. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Kellis.
Aye.
Linda Stanich.
Aye.
Oleniki Toobola.
Aye.
Rachel Dennis.
Aye.
Philippa Nesta.
Aye.
Rachel Mitzel. The motion is passed.
Okay, to move to 62.
Please.
Division 62 addresses certified nursing assistants and certified medication aides. We found a slight error in rule number 0071, reinstatement of CNA certification in the track changes version. It should read as it does in the clean copy on page 337 of your packets. An individual whose NA certification has been expired for more than 90 days, but no more than 2 years may apply for reinstatement. Just wanted to make note of that edit. These updates otherwise are consistent with the broader modernization effort, ensuring the definitions, terminology, and renewal requirements aligning with Division 1 and 31. These updates also reinforce consistent expectations across the workforce and support a better transition pathway between CNA, CMA, and RN roles. A few public comments touched on whether or not for LPNs or CNAs, work as a technician should be received credit towards practice hours. In light of the removal of practice hours, we made no changes as that is not needed or necessary. The concern, while important, has been addressed. No other testimony was received on Division 62 and staff recommends adoption as modified.
I think we're ready for the motion.
The board approves adoption of OAR 851-002. Wait, I'm reading the wrong motion. Let me back up and go further up on the page. Sorry. The board approves the permanent adoption of proposed amendments to Chapter 851, Division 062, rule numbers 0011, 0050, 0061, 0070, 0071, 0075, 0090, 0110, 0114, and 0116 as modified effective January 1st, 2026. So moved.
Second.
It's been moved and seconded. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Kellis.
Aye.
Linda Stanich.
Aye.
Oleniki Toobola.
Aye.
Rachel Dennis.
Aye.
Philippa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion is passed.
And the board approves the permanent repeal of Chapter 851, Division 062, rule numbers 0072 and 0115 as presented effective January 1st, 2026. So moved.
Second.
Been moved and seconded. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Kellis.
Aye.
Linda Stanich.
Aye.
Oleniki Toobola.
Aye.
Rachel Dennis.
Aye.
Felipa Nesta.
Aye.
Rachel Mitzel. The motion is passed.
Thank you very, very much for the conclusion of these rules. And we very much appreciate your true engagement and the questions that you are asking us, and also the limits of the roles that we serve for you as your board staff. Thank you.
Thank you. Those were a long time coming, so done.
I want to just add that the policy analyst did so much work on this and doing the background and the heavy lifts, and it was really a group effort. And I don't think that we're there, but we're like, as far as like, there's always more work to be done, right? We're never complete. But I'm really looking forward to having this foundation and then moving forward. I think we're gonna do good things with it. So I'm excited. Thank you.
All right, so our next item on the agenda is changes to Division 2, which Chief of Staff Goddard is going to present to us. Executive Director Prusak is.
Instead of Director Prusak, so, apologies. In any case, so this before you today is temporary rulemaking. OHA, we pay a fee to OHA, and I'm gonna talk a little bit about that, but basically this is just a temp rule because they are changing their rule and their cost to us, and we have to update our Division 2 fees. So with that, does anyone have questions before I read the memo? Okay. So I respectfully request that the board initiate a motion for proposed rulemaking concerning the Oregon Administrative Rules, Chapter 851, Division 002 of the Nurse Practice Act, which outlines agency fees. On October 15th, 2025, the Oregon Health Authority held a rule hearing to discuss the necessity of raising the fee for the healthcare workforce reporting survey. This fee is paid by individuals applying to renew a license. As specified by ORS 676410, the fee is intended to be reasonably calculated to reimburse program expenses incurred by Oregon Health Authority. All workforce data collected by Oregon State Board of Nursing is transferred to OHA in accordance with an interagency agreement. OHA has reported that since 2021, the program revenue has not fully covered their expenses, and this gap has continued to grow. As a result, they will be raising their cost from $2 per year to $4 per year. Given that OSBN fees are calculated in a 2-year cycle, this translates to an $8 fee per renewal for our applicants. Considering this development, OSBN must amend 851 851-002-0010 to adjust fees and 851-002-0040. OHA's rulemaking notice is included on page 342. Any questions? Mm-hmm. Okay, I
Is
have.
that Elect Hill? Did you have? Oh, sorry.
I have 2 motions. Okay. I move that the board approve adoption of OAR 851-002-0010 sub 4 and 0040 sub 9 as presented as a temporary rule effective January 1, 2026.
So moved.
Second. It's been moved and seconded. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toabola.
Aye.
Rachel Dennis.
Aye.
Felipa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion is passed.
Thank you. I have one more. I move the board approve initiating the rulemaking process by providing notice and opportunity for public comment on the proposed amendments to OAR 851-002-0010 sub 4 and 851-002-0040 sub 9 as presented.
So moved.
Second. It has been moved and seconded. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toabola.
Aye.
Rachel Dennis.
Aye.
Felipa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion is passed.
Great.
Thank you.
Thank you. We are scheduled for a little break. We're running nice and ahead of time. Could we maybe reconvene after 15 minutes at 10:25? Would you want a longer break?
We just took a break.
Okay, I mean, yeah, John Etherington is in the room, ready to go. Okay. So we're down to page 356 for the fiscal status report. Give it to pull that up.
Thank you, Board President. Members of the board, my name is John Etherington. I'm the Fiscal and Operations Manager here at OSBN. I'm here to present the early 25-27 fiscal report on page 356 for us. So while it is early, the first 2 months of the 25-27 biennium, we see really no concerns early. We start at the left column on page 356, which shows our biennial budget. Divides it into the different section of the personal services, which is 19.1 million for our next biennium, our services and supplies of 10.3 million for the next biennium, a nonprofit to the Oregon Wellness Program for $500,000, and the Oregon Nursing Advancement Fund estimated at 952,000, which gives us a total biennium budget of 30.9 million for 25-27. The only part of that category I highlight is the pending 25-27 salary pot. As we have a note to the right of that, our salary pot is money that's given by the governor's office after the LAB. Usually there's some union negotiations, contracts that are still happening at the end of the LAB. And this is to kind of catch each agency up with different changes within the new union budget, which could be COLAs or things that might affect our budget at the end of the biennium. Last biennium, it was an additional 1.6 million. We estimate it to be about the same for this biennium. So I would add about another 1.5 million to our budget probably for 25-27. As we move to the right, our expenditures for these 2 months have been just under or just above 2 million. Our projected expenditures in the middle for the next 2 years is 29 million. And this estimated expenditures would put us just over 31 million, which would be a little bit short of our budget at this time. But given that we have still the 2 years, we'll figure we'll make that up probably in our adjustments and with the salary pot. Moving to page 357, this breaks out all our expenditures just by the different divisions within Oregon State Board of Nursing. Nothing to note on this page, just a breakout of expenditures. And on page 358, these are all of our revenues to note. Currently, we have an estimated total revenue just over 31.6 million. Our LAB revenue was 31.7 million, so it's a little bit short than we estimated. But again, over the 2 years, we would figure we'd make this up. So we tend to be right on track with what our biennium budget estimates were, both for expenditures and revenue. And at this time, that is the fiscal report, and I'll take any questions.
I have a question. Does this reflect the re-engagement with the HPSV? Because I was looking at their report in the board packet of how much it costs per month, and it seemed like $91,000 a month, divided over Board of Medicine, Board of Dentistry, Board of Pharmacy, Board of Nursing, but we seem to have the bulk share of that. Is that reflected in this report at all?
Yes, Board Member Missel, members of the board, that usually falls under the services and supplies category. So while that does incorporate that and other things within our services, that's where the HPSP program falls. And budget-wise, yes, we've continued to fund it. We've continued to be involved in it. There was a discussion previously to get out of it, but we've never moved the funds or taken funds away to not fund the program. So.
I have a question. This might be more for licensing Director Fox, but I'm wondering about revenue. Earlier in the year, there had been big increases in licensure and increased revenue that was associated with that. I'm wondering how, if that trend has changed, if, you know, there was just a really big bump earlier in the year and now there's sort of less licensure, or what kind of trends you're seeing with revenue related to licensure.
I think that might be a little bit more for Mr. Fox with revenue and licensure. We also see in these early stages, because we kind of go on the date of birth, or we have previously the date of birth, different months tend to be very higher in our revenue cycle when people are renewing. So sometimes we do see these summer months, people just don't have a lot of birthdays on those, or the vast majority. So we see a lot more revenue kind of come in October, November, where we actually have more licensees with date of births. So different months do have a little variance of that. But as far as the actual licensing, if licenses have gone down, we haven't seen that, but that would be a good question for our license manager.
And when does your fiscal year start and end?
Fiscal years start on July 1st, and then they end the June 30th. And then the biennium goes 2 fiscal years. That's just July and August, yes, through the end of August report. Given that we do have to give these reports a month in advance before this board meeting, yes, it just goes to the August and doesn't show September and October numbers too. Correct. That's the remaining balance to the June 30th of 2027 date that we would have.
I think I asked this a while ago, but I forgot the answer. The civil penalty, where is that incorporated into there?
The civil penalty is a revenue section, and it's in page 358. It would be under the RN LPN programs. So the revenue that we collect from civil penalties goes into our revenue report.
Thank you.
How is it spent?
How is it what?
How are civil penalties spent? If it's just part of, is it part of like the general revenue pot? And then but how is, or is it dedicated to certain, do we spend it a certain way, or how?
Board Member Mitchell, members of the board, all money kind of goes into one pot. So we have one treasury account, all fees and money that we get in goes into one pot, and then we can disperse it through our expenditure limitations and how it's dispersible is told by the LAB.
Maybe
But as far as the revenue, it kind of just all goes into one.
And maybe to get what you're asking about, maybe we can clarify with Chief of Staff Goddard. But what I recall was there is statutory limitation on how, because we'd had the thought like, oh, we could earmark civil penalties for a specific use, and it ended up that there was a statutory limit.
I'm happy to get some information and get it back to you directly. I don't want to speak out of turn or get it wrong while on record, but I will say we are limited by statute on what we can or cannot do.
Any further questions?
Well, thank you so much.
Thank you.
And next we have Communications Director, Manager Holtree on, and we can turn to page 359.
Okay. Mr. President and members of the board, I'd like to provide a brief communications update. I won't go into everything in my memo because it was lengthy, but just to highlight a few things. The implementation of the Gov delivery software last November has greatly enhanced our communication efforts and is a definite improvement over the old listserv system that we used to use. It allows users to easily sign up for topics of interest for them and allows us to target certain audiences for our messages. It also provides consistent branding and analytics for whether the messages are received and how many people are consuming the information. We use GovDelivery for almost all of our main communications. We use it for the monthly news bulletin, rule hearing notices, RAC and other group communications, rule change advisories, news releases, and also the automated license renewal notices that go out at the 30 or the 90, 60, and 30 days. So it can do all of those things, and it's wonderful. As I mentioned, the monthly news bulletin has proved to be very successful. Each month we feature a few regular features and a variety of new and rotating topics. It is sent to all licensees, staff, and interested parties. The analytics for those bulletins have been very good. For the October bulletin, we had a 63% open rate. The typical open rate for these types of emails coming from a government entity is only about 34%. So you should find on page 361 of your packet a list of all the topics that we've covered in the monthly bulletins for the past year. We've gotten a lot of information out, and I'm pretty happy with the whole thing. The redesigned agency intranet is approaching its 1-year anniversary. It launched last December, and it is updated regularly. It features internal agency policies, a new employee resource binder, an agency event calendar, links to pertinent state information, such as Workday, and also IT help tickets and other employee information articles for the staff. We recently added a page for relevant training options, and I update that weekly, or I try to. Lastly, I've been working on refreshing a few website pages, including the page where the practice statements and the frequently asked questions are found. The policy analyst did a marvelous job of updating all the statements and the FAQs. And then I reorganized the page and added a search feature so it's easier to find topics of interest. I plan on doing the same with the page where the Sentinel issues are linked. So if you're looking for a particular article, it should be easier to find. And that's all I have for today, if you have any questions.
Thank you, Barbara. That's really good news. And you've just done such a great job with all the communications. I know I get them now, and because you sent me the email, and they're great. I open it. So I'm one of your 63. I was wondering, is there a way we could have some sort of education on, some of the stuff we see, like simple stuff, HIPAA violations? Just a refresher for nurses, like don't click into those patient charts and.
Yes, Board Member Callis. Sometimes we have covered those kinds of things previously in the Sentinel. Sometimes those come up as a case study on investigatory cases that are de-identified and just covering topics broadly as a reminder. And that's something we can certainly refresh.
Thank you.
Can I just add really quickly that the communications efforts have been phenomenal, that the engagement number that we're seeing as people are clicking on things, the feedback that we received has been incredibly positive. People are excited to be hearing more from the board, and the communication is just, it's been a focus this year, so really pleased with how it's going.
I love the Sentinel. I think it's great. So, but I was just wondering too, I wonder if to actually get even more engagement, there might be a possibility to feature some of the like DNP students' work, maybe. Like if they have an interesting project or like there's a chance for them to get published and
That's certainly a possibility we could explore. Anything else right now?
Thank you.
Thank you.
All right. Yes. Licensing Director Fox, please.
Great. Board President, members of the board. President Cooksey, do you want me to respond to your question from earlier?
No, why don't you please do your whole presentation?
Okay.
Because it might answer my question anyway.
First, I'll start off by saying I have an error right at the beginning. It said 2024 instead of 2025, which one of my staff members pointed out to me this morning and said that's a January mistake, not a November mistake, and I agree. But yeah, I'll get right to it. So staffing and procedure updates for the licensing department. In 2025, the department experienced key staffing transitions. We had 2 retirements, and we onboarded 4 new team members, 3 public service representatives, and 1 law enforcement data specialist. We're now fully staffed and well-positioned to begin 2026 with strong operational capacity. Over the past 10 months, we have prioritized internal improvements, including updates to procedural workflows, cross-training staff, and ongoing evaluations of our customer service delivery. In preparation for upcoming rule changes, we have begun drafting revised application instructions and eligibility criteria. Once formally approved, which was this morning. These updates will be reflected in our website's instructional materials to ensure clarity and consistency for our applicants in 2026. Application timelines for licenses and certifications for 2025. The licensing department has made significant progress since the beginning of 2025, when we experienced a 198% increase in nurse license applications in Oregon. We are no longer facing delays due to high application volume. Licenses are now issued the same day we receive all required documents. As of October, the time from receiving a transmitted background check to updating our system is measured in hours, not weeks. And most document reviews are completed within 2 business days. While we're proud of these processing times, our priority remains accuracy over speed. Our application review project is actively maintained every day to ensure errors are caught and communication with applicants remains timely. For 2026, we aim to enhance our outward-facing documents to increase transparency in the license application process. The time between submitting an application and receiving a license depends on how quickly we receive the required materials from our applicants. So one area of growth for our department is developing resources to help guide prospective nurses through the steps of obtaining their license in Oregon. We plan to update the licensing resources on our website and continue strengthening and our proactive customer service to ensure the best possible experience for incoming nurses. Our contact center, since opening, the contact center has steadily improved service levels and reduced wait times. In October, the average caller wait time was only 1 minute and 23 seconds. And the center has handled an average of 71 calls per day year to date. Monthly call volume in 2025 averages 1,284. A figure influenced by our elevated activity at the start of the year. We had 2,703 calls in January and 1,829 calls in February. So we're not at that anymore. In addition to phone support, the contact center has responded to 47,203 messages at the time I was writing this board memo from our applicants and licensees through the online licensing system, which averages out to about 232 messages per day. I'll take any questions.
I want to first congratulate you and the team really on all those improvements. First impressions really matter. And for a lot of people there, when they're getting their initial application, that's their first point of contact. And when I got my endorsement over a decade ago, it took over 2 months. So that's amazing to hear where you're at right now.
Yep. Well, last week we had some applications issued within 12 hours of being submitted, which is awesome.
Related to my question earlier, because I was thinking about the revenue piece as well as the trends. Have you noticed sort of the month to month as the year has gone on? I was specifically, I guess, asking about the endorsement, the out-of-state endorsement increase.
It's
that we've
definitely
seen.
tapered off significantly since the start of the year. It got back to average levels around April. And as far as like our revenue goes, I think just the vast majority of our money is from renewals. Just the volume of renewals that we have is quite significant.
So at least an average level, but not a decrease.
Yeah.
From where we've been.
I believe we have more licensees this year than last year. And it's been.
I can imagine. Yeah.
Yep.
I'm just,
Sorry. Hang on 1 second.
I was just curious, what are most folks calling or messaging the board about? What are the questions?
One of our most common questions is the OHA survey. Just how long it takes for it to refresh, because often people will take the survey and then it takes a few hours for it to sync with our system before it allows them to go further. So that's one of our common questions. Just asking about, where do they send their transcript? Just general questions about where things should go, which we do have on our application instructions, but we think that we can still do better about how we present that on our website. So in the licensing department, we're going to be working on additional how-to documents that we can get posted to our website, because as myself included, when I go through an application, I usually go pretty fast and I don't look back. So it's good to provide those resources in multiple locations so people can find them.
I'm in the process of renewing my license right now, and I really want to say how much I appreciate the fact that it's all bundled together when you have multiple license and you don't have to renew each individual one. I really wanted to say, I really love that.
Can't take credit for that, but I'm happy for that too. Any other questions?
I have a question. So when people are submitting their disciplinary reactivation, and we see where people have missed an item, does the system now have reminders of is there a checklist that they're given that says they've got to be fingerprinted, they've got to provide this.
So any person applying for reactivation is going to need to complete a fingerprint background check, disciplinary or just a regular reactivation. So that is something that we'll always be ensuring that people are doing.
And is there some type of follow-up reminder they get for that?
Yes. So initially when they apply, they'll be able to see that in the instructions. And then we do a rolling check on pending applications and do outreach. So often we'll see 1, 2, 3 attempts from licensing staff to remind them, it's like, hey, we see that you don't have a fingerprint appointment scheduled yet, because we can look to see if they've even scheduled it. And so we'll check before reaching out, because if they've scheduled it, we're not going to bother them about it. We're going to wait for the results. But yeah, we do consistent reminders. There's not something that automatically happens. So that is something that we manually have to be checking, but it is something that we're consistently doing.
Fingerprinting comes up for people with initial license and then folks who late renew.
I'll say not for late renewal, but for reactivation.
Yeah. So I thought if it was
Super late.
I thought if a new renewal was beyond the current rule of 30 days, then it requires a.
Yes, so beyond 30 days, I would consider that a reactivation.
Oh, okay.
So up to 30 days late would just be a late.
I got the distinction. Yeah. And so then those reminder emails go to both types of the initial applicants and.
Yes.
Okay.
Yep.
Great. Thank you so much.
Thank you.
We are ahead of time for once. So maybe, so I want to see, there's probably some things we can move ahead on the agenda, but I want to take maybe a break so we can gather ourselves for 15 minutes. So we'll meet back at 10:50.
rules. Within Division 21, our standards for nursing education, APRN programs are required to award a doctoral degree for any APRN education. Those programs are required to maintain national nursing accreditation. And the board may recall that national nursing accreditation requirement is newly in rule, but these programs to become approved and accredited. What am I trying to say? These graduates have to graduate an accredited program, excuse me. The doctoral degree requirement, the history behind that is that has actually been in rule since 2019. So when we updated Division 21 this past summer, we left it because it had already been the standard. And so we're re-looking at that now. There is a discrepancy with how the APRN licensure requirements are written in Divisions 31 and formerly 53, although we just voted to repeal that division. But the licensure requirements for an APRN allow these individuals to have either a graduate or postmaster's degree. They do have to have that national certification and their Oregon RN license. And so here we see Oregon being an outlier. After myself and board member Hill returned from the NCSBN meeting, we conducted a survey of all boards of nursing to see what they required for APRN education programs. What we found is all other US states allow these programs to award a master's degree. Oregon is the only state we found that required all APRN education programs to offer exclusively the doctorate. And so we do see this very much putting us out of alignment with other states in this national trend. And so our goal would be to align the APRN NPA standards with the national norms for APRNs.
So all this is happening in the midst of some critical shortages that we have in the workforce. So particularly around mental health. And recently there was a task force that was put together and they developed a report. And one of the solutions that was brought by this committee was more PMH&Ps, right? And we want to get more PMH&Ps into the workforce, and Oregon has heard this message. So our DNP programs already have started those programs, and we've heard of 2 that are in the pipeline, one we're going to talk about today. So the cries for help for more PMH&P educated nurses is out there. But I think it's important to show the differences between the DNP degree and then the MSN. So the slide, I think, speaks for itself, and it talks about the duration and the number of credits. And so if you were going to try to get back into the workforce or you were going to get a postmaster's certificate, most people are going to make that 2-year decision, not the 3-year decision. Next slide. So the cost consideration. So I looked at all the options here in the Oregon programs, and that is an accurate number of the costs of the DNP to education here in Oregon. And that's significant. And as well as nationally for a master's degree. I think that also sort of speaks for itself. Next slide.
And so we are respectfully bringing forward the concept of a rule for the board to consider. And that is that potentially if a single line in one rule in Division 21 was amended, it would allow Oregon's current excellent APRN programs to continue to provide both doctoral education while also allowing the option of offering a master's level degree or a postgraduate certificate. Here, the language we chose to go with, which we thought was the clearest and broadest, was simply to say graduate degree or postgraduate certificate. We believe that this would retain the high level program standards for our APRN programs. Safeguards would include that these programs must continue to be accredited with the appropriate accrediting agency. Their graduates would still require to obtain national certification, and these programs would still retain those advanced 3 Ps of physical assessment, patho, and pharm. And so here is potential board action, is potentially we could return to the board in February to vote on initiating the rulemaking process, if the board desired to see this change in rule. If the board voted to initiate rulemaking process, we would hold the public hearing and comment period in March, potentially bringing it back for the board's permanent adoption in April. We, as board staff, would do education and outreach in May and June, with these rules becoming effective in July.
So in summary, this alignment will address the regulatory clarity, support behavioral health workforce development, and enhance equity and efficiency for our applicants. We both welcome the board's feedback on this proposed concept and any priorities you'd also like us to incorporate as we move towards formal rule drafting. And our last slide here shows a line from the healthcare workforce survey. And you can see in the third paragraph there that a healthy Oregon includes integration of PMH and Ps in the primary care setting. And now we're open for discussion.
Well, so I think this is a great discussion. One question, I was an advanced practice registered nurse with a master's back 20 years ago. And so I wonder if you could share with the board why the DNP was created. Why, because there was impetus behind a DNP. And I feel like that's kind of a nuance we didn't discuss.
Sure. So I've presented to the board about the DNP in Oregon, and I think the elevator speech for the DNP versus the masters is for someone that's looking to be involved, not necessarily just in practice, but someone who has aspirations to be in leadership, to be in policy, to understand how systems work. And so you tend to see people that obtain the DNP in those type of positions. Globally. Additionally, the benefits of the DNP are 500 more hours of clinical practice. So when we look at outcomes data, they're the same as far as being, safe and making great decisions. But the big differences there are the additional education and layering of leadership, policy, systems thinking for that doctoral level, as well as research. I did leave that out.
And really translational, specifically research. But I guess that systems thinking, my understanding is that the DNP was decided that this was like the goal, this has kind of been, I think most of the national organizations have advocated for a DNP. And that goal was because that systems thinking was critical. It wasn't just, and I think that's where the master's programs, it's the individual patient practitioner relationship. And so the DNP brings in those systems issues, which I think are still important. I just want to make sure that we're having a full discussion about this because I do think that a master's option is but I just want everybody to be aware of those other pieces and that value of the DNP.
Yeah. Board Member McKinley Yoder, I am in complete agreement. And we actually heard that, Board Member Hill and I heard that exact discussion at the NCSBN meeting. And the thinking in the presentation, we heard the presentation really spoke to, we have these desperate workforce shortages. The DNP is preferred and aspirational, but in a time of need for patients, the push was to consider allowing programs to offer a faster option to get people in the workforce faster.
I think of it a little bit as for one piece, what are the minimum standards we expect? And those things can sometimes also turn into barriers to entry. And there's always that counterbalance between what are the minimum standards we expect and how much of a barrier to entry is that minimum standard worthwhile for the barrier that it creates, right? And I think as the policy analysts have spoken to, and we see in other states, a lot of the idea is that nurse practitioners and APRNs have in other jurisdictions really worked with the masters as the minimum standard, and the doctorate nurse practitioner as an option for that higher educational level. Just as the refresher too, I've probably done this before, but like the history of APRNs really going back to the nurse practitioner piece in Colorado really came out of need. And it really came out, and there was no master's program originally, it was a training and a need piece. The real push for the doctorate of nurse practitioner, when I look at it historically, didn't appear to come out of a big push for demand or need in the sense of client care. It came out of, as the analysts have spoken to, and you've spoken to too, this piece, a piece of parity, a piece of analyzing and having the greater level of education and ability to break things down. And I really appreciate that Board Member Hill brought this forward for further discussion to really understand why Oregon is an outlier in this. So I have one question too, just for any institutional knowledge here. Why Oregon made that decision in 2019? Why the board, I guess, if anyone knows what the discussion was from the board in 2019 to.
I was in Afghanistan. So I can't speak to the discussion. I can postulate that it's the goal, right? We want nurses to be prepared at the highest level, and Oregon sets the standard, and other states look to us often for how we conduct business, and they look to our rules and they look to our advice when they have issues. And I think it's not unsimilar to every nurse should be a BSN prepared nurse. And I think that was felt tremendously around the education programs that we have in Oregon, and they uniquely supported that decision. In turn, and this always happens when we write rules, there's unintended consequences of any rules that we adopt. And so that decision put people that were not looking for that doctorate level of preparation to choose outside of Oregon programs. And so I think, again, they had support. It was an informed decision, and that was the decision that was made at that time.
I have two questions, if I can speak. Okay. First question starts with a comment and then a question. So one of the things that I was told in my outside postmaster's certificate program to be a PMHNP was that the job market was saturated. Have you looked at, by my institution, there are my instructors are like, there's so many of us that in FNPs, the time from graduation to first job sometimes is a year. Have you guys looked at our Oregon graduates, how long it's taking them to find job placement?
I have not per se, but that would be an interesting study that we could certainly obtain.
Second question is, I know that since I had been a student in Colorado, their licensure requirements for prescriptive privilege was 760 hours and increasing. I know that Oregon, we only require 450 hours. So is it one possible that was the push for the DNP, was to include the exposure of clinical hours? As you said, it's an additional 500 hours. And two, do you think that will have any kind of impact on practice by opening up masters and postmasters with just such a low clinical hour requirement? And what is it compared to other states? Like, how many hours do other states require?
So that's a great question. So this gets into what should be regulated and what should academia determine is their minimum requirement. So one example nearby is, I know that WSU's DNP program, they require that there's a certain number of hours as a FNP before you can come back and get your DNP. So interesting, right? So there are all types of nuances in what states require versus what accreditors require. So accreditors for many, many years required 500 hours. And at one time we had 500 hours in our language. At some point, that number went out of 53, now 21. I don't think we speak to the hours. But we speak to it must be an accredited program, and therefore accredited programs recommend 500. There was a move a couple of years ago by NOMF, which is the National Organization of Nurse Practitioner Faculties, to change curriculum so they would be 750 hours minimum. Now, some schools require that and some schools don't. Some states require that, some don't. And so we were all ready for the Oregon programs requiring a doctorate. So that just says that's 1,000 hours. So I hope that answered your question.
It was more of, yes, that was like a great background. So thank you for that. I was just wondering is if we go into this proposed timeline of discussion, those were a couple of questions that I would definitely want to talk about further. Like with lowering the requirements to a master's degree, are we going to look at clinical hours and then the impact on the workforce for our Oregon graduates?
Thank you for that question, Board Member Mitzel. I wanted to elaborate a little bit more on the clinical hour requirement in that Division 21 actually doesn't establish the number, not for any level of nursing education programs. And that is because partially this push towards accreditation, we want programs to meet the standards that their accreditors have set. That way they're not in a position where they're trying to meet our standards and they're trying to meet the accreditor standards. And we've also seen a trend where a lot of states are removing a specific number of clinical hours because we know the challenges around clinical placements. We know that sometimes there's variability in students' progression through a program, and wanting to ensure that every student gets that minimum number of hours can sometimes be a barrier. There's also interestingly, a lack of evidence as to you need this many hours to be competent upon graduation. Every nursing program is a little bit different. And so our rules don't specify the number of hours, allowing programs flexibility, but also they are still held to a standard because they're still required to be accredited. So there is not an hour requirement for APRN education in our rules.
Turn to Board Member Callis.
Thank you for your presentation. When we look at the states that have the masters prepared and then you compare that to Oregon, is there a scope difference in the education?
So that varies wildly. Basically, positioning of where the states are in our map. So traditionally, states in the West have individual or independent scope of practice with the exception of California. And several states in the South require to have a practice agreement with a physician. Part of NCSBN's push for the APRN consensus is also to have the same level of scope in every single state, but there are also qualifiers in that language that don't apply to Oregon because we've been vastly independent here since the 70s. And we've had prescriptive authority and had independent practice and business owning for years and years and years. And so, yes, but in Oregon, we've sort of set the standard and set the way. And as you read, hopefully in the Sentinel, that we don't have issues with discipline in regards to practice for our advanced practice nurses. And these are the same standards that we have in coming to Oregon is that master's level. And, again, that it's an accredited program. So in all that time and all the 20 years of that experience, that has been the bar and that has been the standard for Oregon. I can't speak to different states that have different bars, but that's the history why ours is where it is.
So if this change went through, the education would come way down and the scope would stay the same. Is that correct?
So I wouldn't say that the education would go way down. So they will be exactly the same standards of education that they have always been. The difference in the DNP is more clinical hours and different courses outside of the traditional track. So my hope is that with this change, that this also allows the Oregon programs to add postmaster's certificates to their already doctoral options. And when, having stakeholder conversations with them, they said they would not change practice. And for years and years and years, we've been accepting master's people into the state with that same level of preparation, and that is they've met the minimum standard.
Thank you.
Yeah, I have a little anecdote related to that, and I'm glad that you highlighted the mental health nurse practitioner shortage. At my place of employment, there in the jail, Multnomah County jails, there's a lot of demand for psychiatric care, and psychiatric nurse practitioners provide almost all of that care. And we had, I think this year or the past year, maybe 8 new hired. Every single one of them was out of state. Was coming from out of state education. It just which spoke to there's a shortage in this marketplace, and this is one of the pieces that's a limitation unique to Oregon's marketplace for higher education that other states don't have.
I had another question too. Would it at all affect the educational preparation of the faculty?
It would not. We would continue to remain our current standards for the nursing faculty in the program.
Isn't our current requirement though, at or above? So it would actually, because then you could have a master's prepared faculty in a master's program, whereas right now we have they have to have a doctorate. Is that right?
A certain percentage.
Is that pre-licensure or is that graduate too? Okay.
I think as in regards to leadership of tracks, they do require a doctorate level. And that has been the case prior to 2151 merger. In regards to faculty that can teach, we've had master's prepared nurses teach as long as I can remember. Certainly the goal of all of us is right to have that terminal degree, to have the PhD, to have the doctorate, but that's just not a reality.
Well, I just thought all faculty, like you can't have a associate's degree nurse teaching in a bachelor's degree program, right? So you'd have to have somebody at or above the degree that they're seeking.
We don't have that distinction here in Oregon and in 21, because again, what is the degree and what is the qualifier? So if the qualifier is being an advanced practice nurse, you meet those requirements. That it isn't that you have to have the doctorate. They wouldn't teach those courses.
I just want to point out we have a board member online that's raising their hand.
Oh.
Hi, can everybody hear me?
Yes, we can.
Okay, thank you all for the discussion. And I was just going to appreciate this presentation so much, and the background also of what has happened historically. And I just wanted to highlight something. I forgot who mentioned it, but it's really helpful to create that flexibility in Oregon, because it brings more people into the workforce, but to also understand that for some of us who choose a doctoral route, we don't want to be an APRN. It's because we want to work in a system mode. And the systems background is really helpful, but it's also not for everybody. Some people just want to focus on patient care, and that's really all they want. So Oregon being open to having that helps actually encourage a lot of nurses out there who want to pursue that, but taking a doctoral route will cause a lot of detrimental financial effect to them, taking time off work, not being able to work as much as they want to, and that actually holds them back from pursuing a higher degree. So I just wanted to say thank you for this presentation. I really appreciate it.
So we have another 15 minutes if we wanted to address the 2 items that we pulled from the consent agenda that were, I don't know if people want to probably log back into their the beginning section. We pulled the APRN clinical placements, which is on page 10 of our packet, as well as the piece about the decline of PhD prepared nurses.
So President Cooksey, members of the board, you had asked me this question at our last meeting, and I didn't know how long the meeting was going to be today, and I wanted to make sure that I addressed that question. So that's why I put it in the consent agenda. I resourced it. I looked on the national level. I prepared data for you to answer those questions, and I didn't have it as part of an environmental scan. And that's why I put it in as a consent agenda, and I'm happy, as well as my consultant friend here, to talk about the PhD.
Yeah, why don't we
say crisis, but certainly there's, it's been on decline for a number of years, and then the ever-existent clinical placement problem.
I think Board Member Mitchell had some questions about the APRN clinical placement piece first.
Yes, first off, thank you for putting this together. I was really surprised and happy to see it. One question I had too is I know that it's not just APRN, but also RN clinical placement issues. And one of the things that I was curious about too was, did you look into some of these fee-for-service clinical placements? And I think I had shared a recruitment letter that I had received from an outside out-of-state nursing program, I think Frontier University in South Dakota. And when I went down to the exhibit C-E1 of the board packet, I didn't actually see them as one of the non-Oregon programs that had its students registered.
We don't ask APRN programs to report out-of-state clinicals in Oregon. We had in the past, and we changed those rules approximately 2 years ago, I think. And so we no longer have them report to us.
Oh, so we don't actually know how many schools are placing students in Oregon?
At one time, 2 years ago, we had 53 different programs.
Okay. I'm just wondering if that is a significant factor in clinical placement for our own students here in Oregon, especially if preceptors are choosing to go with this. I think the company was called NP Match, which then had offered, it was something like $2,700 to be paid to the preceptor in exchange for a number of clinical hours. So I'm just wondering what that effect would be like overall.
Absolutely. So this is existing. This has been an ongoing issue. And then I think as policy analysts, we go to statute. And what does the statute provide for us to be able to impact on that issue? Is not there. So there also is fair trade. So schools are a business, and schools can have a business wherever they want, and we can't impede on that as a board. And so I think when you look at those things, it puts us in a difficult position. Where we can affect change or requirements are just that. What level of preparation, what level of hours, what level of requirements do we have for prescriptive authority, let's say, right? And we do have some significant requirements for prescriptive authority in Oregon that other states don't have. So that's where we have taken action. But it's out of our regulatory authority for us to make demands on programs that are accredited by other organizations that physically reside in other states that have their board of nursing and their board that they have to report to, and their accreditors that they have to report to. Would I like all schools to do the right thing and guarantee students clinical positions? I absolutely would. But here we are.
I definitely think it raises some interesting ethical questions.
So I agree. And I guess, so I noticed that you shared with us, and I really appreciate you kind of finding out all of this information. Accreditation, accreditation remains with the programs. So my question though, so if schools are paying for this, and this is not like, I'm wondering if this is something we can do. If schools are paying for this, then I feel like that removes, they're paying incentives to somebody. I mean, there are lots of concerning, we are a profession, therefore people are responsible for bringing up the next group of people, and this not becoming a profit-driven enterprise, which then raises the costs. I mean, there's so many issues, but for me, it's really when an individual student is asked to find and likely pay for their preceptor. My concern is that is a conflict of interest in that preceptor's ability to be honest, and most faculty are not evaluating the student's care. So then that gets to the safety. And so I'm wondering, like, is there something we can do to address that piece? Because that's a major conflict of interest, and that does affect public safety. And you may not have the answer, but I kind of wanted to say this for us as a board to consider, because it's really concerning.
I agree. I think it's a really complex ethical issue. We do know that nationally, there are situations where schools are paying, where schools are telling students to pay, and even situations where students are offering to pay to get their preferred preceptors or placements. And so all of these different things are happening. Again, as Dr. Wickenhagen was saying, our authority over this issue and over clinical agreements between schools and preceptors or clinical sites, it's not something currently within our statutes. And even if it was, we would only be able to apply rules to schools that are located here in Oregon. And so this would not solve the issue of out-of-state schools that are having students complete clinical here, possibly paying for that clinical experience. So it is a challenge.
And that could decrease the number of Oregon nurses that we end up
But if we
graduating.
Their preceptors are licensed in the state of Oregon. So we do have jurisdiction over their clinical preceptors and their ability to receive money and who they would receive money from potentially. I don't know if that's a possibility, but sorry, and Chief of Staff got it.
Yeah, I think this has been a really good conversation, and it's like a lot to take forward and be thinking about and continuing into the next year as we move forward.
The article quickly, or, okay. So same thing, just went out, looked for the data to support what we all have been hearing anecdotally. And it absolutely supports that there's a significant decline in the PhD degree. I've indicated my concerns here in this memo. And it's another problem that we don't regulate the PhD program. It's not a licensed degree. And so that is outside of the scope of our regulatory authority as well.
Do you know approximately how many PhD programs in Oregon are offered?
That's a complicated question because there are different types of PhDs for nurses, to include the EDD. As far as programs that offer the opportunity, certainly OHSU offers a PhD. And then after that, I'll defer to my colleague who's getting her PhD.
I believe Dr. Wickenhagen is correct. I believe there's one PhD program in Oregon, and I believe there's a new EDD in nursing education, specifically at University of Portland. I do not know if George Fox.
I don't believe so.
I think PSU also has an EDD with a nursing focus. Although I do want to clarify that an EDD is not a PhD.
Well,
It-
it is
it's-
doctoral
it's-
level of preparation.
It is a doctoral level of preparation, but it's similar to a DNP or an MD where it's a practice doctorate.
I had a question about your memorandum. When you're looking at the salary gap, where it's talking about recent workforce studies, find that nurse educators earn substantially less than clinical nurses and managers. Is that also including the adjunct faculty in that, or is that specifically just looking at career nurse educators?
So I'm looking at the reference that I have from that, and that's from the Center of Health Workforce Studies. And I honestly don't know the answer to that, ma'am. So I can look and find that for you. Anecdotally, I would say that the salary is much, much lower for adjunct faculty. So that would make it even a larger gap.
Okay, thank you.
Like, I think we got food for thought for the future, and I can tell that the board really looks forward to presentations and ongoing discussion next year in this area.
President Cooksey, we need a vote on the items pulled from the consent agenda.
Oh, okay. Would you like to give us a motion for those two items then? We did already approved it. I don't think.
It was approved as modified by removing the
Yeah,
items.
it was approved as modified.
So these items were removed, so they weren't approved.
Okay,
You need a second vote
On
to
the
address
two
these
that
two
were
items.
okay.
Happy to do it. I move that CAP 1 and CAP 2 agenda items be approved as presented.
So moved.
Second.
Been moved and seconded. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toabola.
Aye.
Rachel Dennis.
Aye.
Philippa Nesta.
Aye.
Rachel Mitzel. The motion is passed.
Policy Analyst Blackhurst, are we ready for your presentation on the pre-licensure education program?
All right, I would love to direct the board to page 366 of the packet. This should be a memo regarding Rogue Community College. So as I noted in this memo, Rogue Community College has an approved practical nursing program and an approved registered nursing program. These two programs have been taught together since 2024. The students take the first year of courses together, and Rogue would like approval to offer those RN students the ability to receive a practical nursing certificate at the end of the first year. Are there any questions about the plan or proposal?
Is the intention so they can enter the workforce and help support themselves?
Absolutely.
Yeah, I think that's a great idea.
Yeah.
I thought it was brilliant.
Yeah, I think it provides a really good opportunity for students if they decide they can't even complete the second year to walk away with a certificate.
I remember back in the day when the OCNI program first started, there was the AAS where people kind of had that option, like you got your the end degree was a bachelor's, but you could step out and get your AAS. But when they transferred to that higher level, it was as if they didn't graduate. So I'm just bringing that up because if they do step out, will it look like you have then, those students haven't haven't completed their program. Anyways, and it's really, I think it's brilliant. I love the idea of them being able to work at that higher level while they're, going to their RN. But just the thought, like, as far as how that might affect your numbers.
I believe the plan for Rogue is that the students would continue ideally in the RN program and so ultimately earn the associate degree. But yes, if they did need to step out at that first year, they would at least have a certificate. All right, are you ready for a motion? Then I'll motion that Rogue Community College be approved to offer the option of a practical nursing certificate to students in their registered nursing program as presented.
So moved.
Second.
It's been moved and seconded. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toabola.
Aye.
Rachel Dennis.
Aye.
Philippa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion is passed.
Then my second agenda item is on page 369 of the packet. Here, there is a memo regarding a continuing approval survey of Concord Career College's practical nursing program. This survey was conducted in late September. As noted in the survey report, all standards were found to either be met or partially met. Recommendations were provided for partially met standards. But otherwise, my recommendation was that this program be granted approval for 8 years till 2033. And it's very likely that we would be surveying earlier because they are pursuing national nursing accreditation. Any questions about this survey?
There was, I think, a list of like who you surveyed students wise, right?
Yeah.
How did you choose those students?
So typically we ask the program in advance to arrange for students for us to meet on the survey. I believe on this survey, it was just randomly what students were available. I think sometimes on a survey though, it does tend to be who's available, who's on campus. Some schools incentivize, offer pizza when the Board of Nursing is there to get students to attend, but it tends to be random.
Do you guys ever survey people who maybe completed that course there?
We have surveyed alumni before when we couldn't find actual current students. But if we have students available, then we don't typically talk to the alumni. A lot of these programs, though, as part of the survey process, they give us hundreds of pages of documentation. And often part of that is summaries of like their post-grad surveys they're conducting, getting input on the program.
I see. I asked because I attended it and I wasn't necessarily a fan. But that's my own personal opinion along with a lot of cohorts I had. So I was just curious.
Yeah.
Thank you.
Of course. Ready for a motion on this one? Okay. Then I motion that Concord Career College's pre-licensure practical nursing education program be granted continuing approval through September 2033.
So moved.
Second.
It's been moved and seconded. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toabola.
Aye.
Rachel Dennis.
Aye.
Philippa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion is passed.
My final item on the agenda is on page 375 of the packet. And this is regarding the Institute of Technology and their application for initial approval of admission for students. And we're very lucky to be joined by guests from their nursing program. We have the nurse administrator, Bonnie Olson, here as well. And guests. So as I noted in this memo, IoT currently has a practical nursing education program. Their application is in regards to a new associate degree registered nursing program that would begin April 2026. Myself and Administrator Olson are happy to answer questions.
Hello, thanks for making it out in person. Just double check our notes here.
I just want to say thank you for being here. I've heard a lot of good things about OIT, and for probably 20 plus years, heard a lot of good things about your sonographer program. And I always wondered why it wasn't brought to Portland instead of Klamath Falls. But we actually had Kaiser partnered and switched from Concord to OIT. So it's very
The IoT?
Mhm.
Are you saying
Oregon
OIT, Oregon Institute? This is different.
I'm
It's
so
IoT.
Oh, wait. Oh,
Yep.
apologies.
I did have a question. I noticed that when I looked at your affiliation agreements, you have people as far away as Medford and the Dalles. Where is your program located?
We are located here in Salem.
And so your students may travel 4+ hours?
No, our students, what our catalog states is our students will not travel more than 50 miles from the campus to their clinical sites. However, we have students from Medford. We have students out east on the coast. We have them in Portland. So we try to place, the reason we have so many different affiliation agreements is we try to place our students closer to their home. So that's why we have quite a few down in the Medford area, on the coast, Eastern Oregon, we have some.
So they can choose to go to these farther places.
Right. I mean, we try to, because they come to campus one day a week, but when they do their practicums, we try to place them as close to their homes as possible. Unless they want to come into this area, if they're from Medford and they want to come here, yes, we will, but we try to place them closer to their homes.
I want to make sure I understood, and maybe I'm mixing it up because I can't quite find my notes, but just kind of global, the brief overview of what the program will look like. Now, do I recall that it was like a 50-week?
It is 10-week terms for the RN program. So it'll be 9-10-week terms. So it ends up being 90 weeks, but with their break weeks in between, it ends up being about a 98-week program because they have a week off in between terms. And then, of course, Christmas break and all of that. They have
over 2 years. And yeah, and then it references like the 4 academic terms. Is that?
What's that?
There's it's referenced elsewhere, like a 4 academic terms. Is that or you said there were 9-10-week.
There's 9-10-week terms. So
and that's over 2 years.
Yes. Yeah. It's ends up being just a little over, it's like 2.5. It's it's like 98 weeks, and that we include their breaks in that.
Thank you. All right, sounds like ready for a.
Then I motion that Institute of Technology's application for the initial approval of admission of students to their registered nursing education program be approved as presented.
So moved.
Second.
Been moved and seconded. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Olaniki Toabola.
Aye.
Rachel Dennis.
Aye.
Felipa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion is passed.
Thank you.
Thank you.
Would you like to entertain delegation of authority since we're so far ahead? I'm looking at where we're at in the.
Yeah, except I think that discussion's not going to fit in a short time frame. So could we take lunch early?
Okay.
And we still have our presentation. I don't, over lunch. They're joining virtually.
Yeah.
Oh, here in person. Okay. Yeah, maybe we can see if they show up and we can start a little early, but is lunch here now?
It is. Let me go verify it's set up.
All right, we'll give it a We wanted to ask the question correctly. It should be called. Yeah, we tried to rush that last time. It didn't work. But we still have addendum, and we have one other addendum item. Uprise and HPSP.
Oh.
So, but I guess Rachel's calling in for that.
I'm actually here now. If we want to move up HPSP, I can turn on my camera and join you all.
Yeah, I think. Hi, voice. You're like the voice of goddess here for us.
That is how you feel when you're on vacation for sure. But hello, everyone. So is that what we want to do?
I think so. Yeah, I think it'd be perfect. We could do that in 10, 15 minutes easily. And
Yeah, okay, thank you. I do, let me pull up my stuff.
yes, us as well. So we're going to go to the addendum board binder. and under HPSP.
And while you all are looking for it, I will say it ended up on the addendum after a conversation I had with President Cooksey and making sure that I was very transparent of the conversations I was having with Uprise as well as with President Cooksey. So once you find your way there, I will read the memo and we can start a discussion. But before I do dive into it, I have been listening along first in the live stream and then joined you all. And I just really want to express my gratitude to the board and staff for the tremendous work you've accomplished over the last 2 days. At every meeting, I'm always looking for ways to better support the board and bring what I learned from the last meeting to the next. But I've also aimed to create an environment where you can excel in my absence. And this month has shown that you are achieving that. So thank you. I also have been listening in, and it's been really exciting to know that today is our last 2025 meeting, and I think the work that we've been doing was really highlighted today. The dedication and the expertise of the board and the staff was able to move work that we have been focused on for the last 2 years, whether it's the effective communication with licensees, certificate holders, and the public, or licensing in a timely manner, as well as continuously working to improve our investigations to be timely and trauma-informed. These efforts have really removed barriers, especially the legislative work and the rule work to modernize our statutes, our laws and our rules to guide regulatory excellence. So I just wanted to give you all a shout out for what I witnessed this morning. And if you are all there, I am going to find my HPSP memo.
I think we are, page 780 of the addendum.
Great. So I really wanted to make sure we had a discussion around updates to the program following a recent presentation from Uprise. Can you guys give me 1 second? My eye, I need to take a second. My eye is watering and it's impacting me connecting with you all.
Nope. Okay. No motion, just discussion update. So yeah, this was after we yeah, there we go.
Oh, sorry, my apologies. After the September meeting during the strategic plan, there were a few concerns raised and we needed to address them promptly. So first, it was brought to our attention that HPSP or Uprise website contained outdated information. And Uprise has confirmed that they're working to update our concerns and have already completed some of those updates requested. And the Uprise team is working closely with OSBN HPSP liaison, compliance specialist Kilborn to continue those updates. Second, there was a discussion regarding reducing the minimum toxicology testing for RN, LPN, and CNA and HPSP from 36 tests to 24 tests per year in the first year. And the current requirements of 36 tests per year impose significant financial burdens that could hinder participation in the program. And data indicates that 24 tests per year are sufficient for effective monitoring. Furthermore, OSBN substance use probation includes a minimum of 24 tests per year. And the board has consistently expressed a desire for HPSP and probation monitoring to align as closely as possible in terms of requirements and program length. So when you all, the board, voted to re-enroll in HPSP, it was with that understanding that the monitoring requirements and program length for board probation and HPSP would be roughly aligned. So we've made several changes to board probation to reflect this alignment. And therefore, after the Uprise presentation, President Cooksey had sent an email following up on the questions that you had after that presentation. And I made sure the email was attached as well as the attachments in that email for you all to see. But that prompted me to meet with Uprise and discuss the necessary updates that you all mentioned and President Cooksey mentioned in his email about 24 tests per year being the baseline. And they will also follow OSBN probation policy for second and third year and allow for 18 tests per year for CNA and those unemployed. And they really did express appreciation for OSBN leading the way. And they're actually starting to collaborate with their internal PAC to discuss CNA enrollment and how they may be able to serve them better, maybe including ways to remove the barrier costs for testing panels and ones that may be a little bit more affordable. On that, I will just say I'm really thankful for President Cooksey and you all pushing me. This was something that's been a labor of love and hard work and effort. And every time I thought I was pushing the limits, you all would remind me that we could actually even do more and do better. So I look forward to the discussion you all want to have, and I'm here to answer any questions.
Thank you, Director Prusak. I want to clarify, because you had the response from Uprise that they were looking to align with the testing that we'd requested. Is there a point at which that's gone, that they've approved that and that's gone live to the 24 tests in year one?
Yes.
Okay, so
they were able to approve it and put it into effect immediately. Right. Yep.
Great. And then the corollary to that is that their website, though they did remove the piece saying OSBN does not participate, they haven't added anything that specifies that piece. They still have the 36 tests per in year one. Is they kind of have their generic info for their physician participants and dentistry.
Okay, we'll make sure that it gets updated. It has definitely. We have been connecting with them regularly, as I mentioned, our HPSP liaison, compliance specialist Kilborn, as well as myself, to do this. And who we talked to and who presented you all then has to go to their IT people, and there can be some steps that they have to take. They're on board with everything they're requesting. We're also working really hard to update and grow our amount of evaluators. As we know in Oregon, there's a limited amount of those that can offer the evaluations that we need. But we're actually working to partner with Uprise to do our own work, since those of us in Oregon have relationships with others in Oregon to grow that list. So it's lots of still work to do to improve, but I do know that they are honest partners and great partners, and looking forward to getting it all done.
Other board members have any questions or input? It was really been part of my pet projects, and being my last board meeting, I wanted to follow through on a few things too. I'm wondering too about I know the work group has looked at some of the outreach efforts and how we're advertising HPSP, and if you could just speak to that, because yeah.
Yeah, you know, Uprise has that in their contract that is part of their work, but I really see it as part of the board's work as well. So I have created slides for policy analysts at every presentation they're doing to incorporate slides about it. I have been giving presentations about it and plan on doing further outreach for any hospital system, clinic system, systems in general that want a presentation about it. And then at every turn, we have been putting it in our newsletter or the Sentinel on updates. I think the news is getting out there because what we're hearing is there have been already self-referrals, although there were self-referrals all along when we weren't in it, but they were having to say no. So I think I can commit to giving updates at every public meeting along the way of what we learn. And then I'm sure in our executive sessions, we'll be hearing about it more too.
The last thing related to outreach, I wanted to encourage when I first found out about HPSP and the boards leaving it, when I looked for kind of resources about the history, the Board of Nursing in March 2015 had like a 6-page facts and side-by-side comparing what is probation versus HPSP. I think that would be very helpful for potential participants to understand. And if you still have that document around, or I've got the paper version here, I think you might have removed it from the website at some point, but I think that sort of thing would help to communicate what the expectations are for enrollees.
No, I think that's great. I'd love to see it. But again, I think that's exactly what we need to show and show the alignment now and show, why it really is the board's discretion of where one is needed over the other, as opposed to someone choosing it because of barriers, financial or otherwise. And I think we can create that. The compliance specialist, when we meet every week, this is now a topic of discussion of all the work that still needs to be done, and we can add that to it. Investigations Manager Ferris, is there anything you want to add since you're in the room and you've been working with me closely in Uprise and our compliance specialist on this?
I would add that we continue to try to remove barriers, both related to the website, but also when it comes time for individuals to seek a licensed evaluator. Currently, that list is one consolidated list on the website. We are working on creating 2 separate lists, one that would contain a list of licensed evaluators and a separate list for treatment providers, so that doesn't get confused by people seeking those resources. But yes, there's a lot of work continuing in with the compliance specialists. And I thank you for this conversation. And I thank Director Prusak for all the work that she's done to make sure that the board is updated about HPSP.
Well, thank you so much for logging in on your time off.
Yeah, no, I will be here for lunch presentation and then a few items after lunch. And again, what I've learned is you all did fantastic without me there. So thank you.
Great. All right, I think we probably, Brandy, do we have lunch set up so we can go grab lunch, and then we'll see when our presenters ready to go. Welcome back. Thank you. We have Mary Dakin presenting for lunch here.
Okay, I'm happy to be here. Thank you for letting me come and just present briefly about some of our nursing education programs for long-term care. My name is Mary Dakin, and I am the Workforce Development Manager at Oregon Healthcare Association. In case you are wondering what that is, most of you probably know, but this is the association supporting long-term care providers. Been around since 1950, 75 years of doing this. And we work with over 90% of the long-term care providers across the state. So that includes skilled nursing and post-acute and CBC contexts. So yeah, I wanted to talk to you about some programs that we've been running, well, pretty much for the last 2.5 years with funding support from ODHS. So the initial program was named Expanding and Enhancing the Long-Term Care Nurse Workforce in Oregon. And that's self-explanatory, but we're really hoping to create support and educational programming for nurses already in or beginning their careers in long-term care because of the very specific nature of that kind of nursing, and also provide more internship and clinical opportunities or more positive supported clinical opportunities for nursing students to help them become aware of what that long-term care community is and what nursing is like in long-term care. Since, I mean, we're all aware that for most nursing students, the big driving goal is the ER, but we're trying to expose them to other ideas. So, in addition to that, we sponsored a scholarship for nurses around the state to take the Gero Nurse certification, so that we sponsored the tuition for the course and the cost of the exam. That's still running, but it's kind of closing up. We only have 2 spots left, and they have to take the exam by January 31st. So we have over 50 nurses who have actually done the certification and several hundred who signed up, some of whom did the coursework, some of whom didn't. You know how that goes. But the people who've done it have been really positive about this course, this Gero Nurse course. And it's nice to, you know, have a representation of the work that they've done and that piece of expertise. OHCA has also included leadership training so that facilities are, you know, consistent with the kind of leadership that you need. And, you know, one of the significant problems is retention. So that starts at the top. We've run a couple of DEI intensives. DEI, the word that shall not be spoken now, I guess. There's another one coming. And we're also going to run 2 cohorts of a leadership academy at no cost to participants, which will be, you know, a 2-day training, and then over the course of the year, events that they attend together and other one-off events and support systems. So that actually the Leadership Academy, we're really hoping to attract nurse leaders to this. Obviously, we love facility administrators and other leaders, but for this particular grant, we're really hoping to support nurse leaders and people who are, you know, even regional nursing directors. But it's meant to support emerging leaders, so people who are newer to the role. And that application is open, and it closes on November 17th to be part of that cohort. Okay, so what I really want to talk to you briefly about is 2 of these programs that are education focused and that are still ongoing. So I'd like to start with the nurse residency program. We all know that a lot of young or new graduate nurses are looking for residencies, and there are never enough. And that this is a way to provide them with sort of sustained support in their new role, and particularly with respect to the context in which they're working. So we are providing a nurse residency program that is for nurses already hired. Their employer sponsors the residency. Well, we support the residency, but the employer provides a mentor. And this involves a 3-month minimum structured mentorship. So there are curricular units that were developed by University of Wisconsin-Madison. They're administered by a Pathway Learning Network. And there are a number of units. There are 14 units for the resident. And there are also 6 or 7 units for the mentor to help guide them in how they might be working with the resident and reminding them about teaching and learning and mentoring. And actually, the mentors who have used it have found it quite useful. The 14 required units for the resident are pretty substantial, and there are additional modules that are on topics that are, well, you can choose whether to do them, and that would also, depend on the context of the facility that you're working at. We're really hoping that this kind of structured mentorship with specific content will help support nurses and, help them stay in this context for a longer period of time. So the program components include, we pay for the residency curriculum. There's a small stipend for the clinical mentor. It's not really a preceptorship, but sort of thing. And we've also made available at no cost some of the additional professional development courses that OHCA offers for nurses. And the nurses who participate in this and then stay in employment at their facility are eligible for a new nurse incentive payment after 3 additional months at their facility. So something similar to a retention bonus. So yes, this program, once it's been, gotten off the ground, it's pretty popular, and we will be accepting new residents to the program through June. So I'm out there, trying to make sure people know about it and recruiting, new residents to make sure that we can continue this. We would love to continue this program in the future. The extra bonuses that I was talking about, the incentive payment and the stipend or the free courses, that's a little harder to pull off without significant funding. But we'd love to see at least access to the curriculum and those curricular units for the structured mentorship continue to be available, after the end of 2026. So that's when this particular grant cycle ends. So we'll be working on that. Another program that I'll just briefly mention, we've been sponsoring capstone clinical internships in partnership with University of Portland School of Nursing and now with Sumner College, where their final placement, their final clinical practicum placement is made in a long-term care facility. There are specifically designed curricular modules designed by University of Portland, only a few of them, of course, because this is not a long clinical period. It's not that many hours. And there are also some support units for the preceptor. And the idea is that we're, hoping to create capstone internship programs in long-term care in the future. Mostly we're hoping that we can attract more nursing students to this area or to senior care in general and educate them about, other areas of nursing. This program is wrapping up at the end of this academic year. We have one more cohort coming out next semester at University of Portland and at least 2 more cohorts from Sumner. It involves a stipend for the interns, stipend for the preceptor, and also eligibility for that new nurse incentive program. So, and I already mentioned the Leadership Academy, the DEI program, GERO BC certification program, and other professional development activities that are components of this program. So I thank you for listening to my little description of our programs. Oh, I forgot to mention that with the residency, while we have some residents at the assisted living level, we have been trying to focus on skilled nursing and post-acute, where it's, sort of most intensive, and also in some cases, some special needs contract units. So thank you so much for your attention. And I'm going to hand the baton to Cynthia McDaniel.
Can I ask a question? Oh, I'm curious. So the internship is 3 months. And then if they sign on for an additional 3 months, that's $5,000, the incentive payment?
I'm sorry. The internship is the clinicals. So that's however many hours that is, 104, I don't remember the number of hours. And then if they take a job in long-term care, they can apply for the nurse incentive after 3 months.
Okay.
Whereas the residency is someone who's already employed.
Okay, the
with
resident
provider.
So residency is 3 months, and then after 3 months.
They're both 3 months, but it's different for the intern because they're not already an employee in a facility.
If they take the $5,000, is there a commitment attached to that? Is it like a year or?
We didn't do that because you can't really legally enforce that.
Okay, I'm just curious. My question is, that I'm trying to understand is, of the people that have stayed and applied for the 5,000, how long do they usually stay for? Are they staying for over a year?
That will be a very good question. We don't have data on that yet because the incentive program has really only just been introduced.
Okay.
So we'll see how this pilot goes with that. So, any other questions?
I have a comment.
Yes, please.
So thank you, Mary, for this presentation because you are actually speaking my love language because I come from long-term care. One of the things that I appreciated 14 years ago when I was an OB nurse for years, and I went into long-term care, and I thought, what do you mean rules and regulations and all of those things?
Yeah.
One of the things that I appreciate is the OHCA conference that you guys have. And I know we've talked a little bit about how the nursing instead of the hours and the CEUs, and that is something that I've always appreciated, that I can get there at those conferences as well. I didn't know that this actually existed, so I wrote some notes down as well.
Great.
And I'd like to connect at some point with you.
I'd love to connect.
Thank you.
Thank you. Okay, thank you, everyone. I'm going to stop talking now.
Hello, I'll ask you to introduce yourself, please.
Okay, Marcus. I'm Cynthia McDaniel. I'm the CEO of Elderwise, which is a consulting and education company, and NurseLearn, which is an online education company. I'm going to go ahead and share my screen. If they don't allow me to do my slide layout. I love it when it just gets in the way. Yeah, you can see that now? Yes. Okay, NurseLearn, education for the community-based care specialty. This is the specialty of nursing. And as Mary talked about long-term care, what we know is that community-based care, which in Oregon rule, we define under ODHS, adult people with disabilities rules, we define that as anywhere that a nurse is not required to be there 24/7. So it's not acute, it's not nursing facilities, it's not hospitals, but it's almost anywhere else. And I always look at Gretchen because we've been talking about this for years and years and years as far as this definition, right? So what we identified years ago is that nurses were not being prepared for roles in community-based care. It is absolutely a specialty, but not necessarily recognized yet. We're getting closer, recognizing it as a specialty. So what is NurseLearn? Well, NurseLearn is an online education company that provides nursing courses on CBC community-based care areas. It started, and here's what is NurseLearn. We provide it in assisted living, memory care, residential care facilities, and adult foster homes. That does not mean that nurses from other areas would not benefit from this. In fact, because of a contract we have with the Oregon Department of Human Services, every licensed nurse in Oregon can access these courses free. And currently there are 30 courses that nurses can access for free. We've also, with that same contract, because we feel that administrators who are non-nurses in these settings could benefit from learning about what the nurse does, because what we've seen a lot is they hire a nurse in one of these specialty settings and they think a nurse is a nurse is a nurse. Every nurse knows the same thing. And what we know is that that's not true. And so if we can educate non-nurses on what to expect the community-based care specialist nurse should be doing, then resident outcomes are better. So licensed residential care facility administrators are also able to access these courses for free under the same contract. Now, when we talk about adult foster homes, NurseLearn also has 10 specific courses that were built for nurses working in adult foster homes that also adult foster home licensees and administrators can access for free. So the intent is to really define the specialty, provide the education, and impact resident outcomes. And we're doing that. We're early on in the project itself. When I say early, I was talking to Gretchen earlier, and we're just now pulling initial data from that as far as what has been our successes, where do we want to go. Part of the program also includes a mentor. And so we have mentors that work with those that are taking these courses and also able to answer questions. So this is a complex specialty. When we look at this, nurses are isolated out there. There may be one nurse for one building in rural Oregon they don't have anyone to talk to. They don't have anyone else they're working with. So how do we create this network? And why I like to talk about the history of NurseLearn is because NurseLearn actually, and this particular program started here, not in this building, but with the Oregon State Board of Nursing, because there were those of us years and years ago, when the Division 47 RN delegation rules began, that met together in advisory groups, rule advisory groups. I think we called them task forces then. And we would talk about how nurses aren't represented, meaning they didn't have a community. They really wasn't identified education. Nurses were coming out of their generalized education and nursing school, really not being able to function effectively in these specialty settings. And when we talk about the CBCNA, actually in 2004, when those Division 47 rules were updated, this group of nurses from this task force decided to form the Community-Based Care Nurses Association that then went into the Community Nursing Network. That is now no longer an association, but NurseLearn grew out of that because I was the founder of that. So this has been a sort of a lifelong passion, if you will, an intent to impact quality for a long time. And because I'm in buildings all the time in these communities consulting, we saw the needs for nurses. They would say, I feel so alone. I need to know more information. I just wasn't prepared for that. So that's the history, which is tied to OSBN. Again, we've talked about there's limited community-based care content in our preparatory nursing education. And we know that that residents who are living in these settings are impacted by the quality of that nurse's ability to assess, to advocate, and to really have a voice. And so that's where this education was born. So again, we talked about free to all licensed nurses, free to these administrators. Right now, there are 5 series. And the other thing is that we also offered them to student nurses because we wanted to pilot that. And we had some student nurses do this for free. And Sumner College decided to do a pilot with us. And so they're still in a pilot. We're still doing looking at the data from that. And we're in discussions right now with other schools of nursing on how we will pilot as they include these in their curriculum, either as part of their, course of study or as some extra credit. So here are the courses. I just thought we'd put the names of the courses there so you can see just what we are offering. There are 5 series. The first series is significant change of condition. And when we talk about significant change of condition, you can look at those that are long-term or those that are short-term, including significant weight changes, falls, pressure injuries, acute health status change. Like if someone has had a stroke, has had a heart attack, how do you care manage this person? Bone fractures, admissions to hospice and uncontrolled pain, all pretty significant. If any of us were living with a change like this, we would want someone that really understood how to assess, intervene, evaluate, monitor, and communicate. The next series is care management with care transitions, restraint reduction, looking at direct care needs. I mean, sometimes the nurse in this community will have to deal with catheters or ostomies or wounds because they don't qualify for home health services. So how do we ensure that nurses are prepared at least to have an overview, ask the questions, and have a foundation? Management of chronic conditions and creating service plans and care plans. For all the nurses, care plans are really quite an area of expertise. It takes a lot of knowledge and understanding to be able to create a plan for someone and then to ensure that it is written in a clear manner that is personalized. RN delegation, this is another series. We waited, these were the last courses that we rolled out in this series because the current Division 47 rules did not go into effect till September 1, 2024. So these actually rolled out at the end of September of 2024, so just a year ago. And these delegation courses were reviewed by one of your experts here for consistency with the rules. Not that she wrote the course, but just did we get it right, Gretchen? And we are, and that's a pretty high bar, right? This is a really high bar to be able to say, yeah, you got it right. So we are seeing definite impacts already from nurses that are able to go somewhere and learn something about RN delegation. And medication systems is our next series. And so again, medication system and community-based care, common meds, the Beers list and polypharmacy, and managing a controlled substance system. You put a nurse in one of these environments and they're supposed to know how to do all of this. And they may have just administered meds or medication somewhere. Behavioral mental health, of course, this is very important. Again, how many people really understand behaviors and behavioral interventions and antipsychotic medications, mental health, and sexual expression and intimacy. All very important topics right now in our settings. And finally, leadership and management. This, in fact, when we do a course of study and we recommend a course of study for onboarding in a community, in a community-based care community, these are some of our first courses because we have found that nurses burn out faster and they decrease their wellness if they don't know how to manage their own time, if they don't know how to work with people, if they don't know how to communicate. So these have been very effective. I wanted to show you this. We're very proud of this in the limited time that we've been doing this because our courses, the first courses initially rolled out in March of 2024, but they rolled out gradually. So the full set of courses were not available until the end of August in 2024. So just over a year. And in that time, we have 722 RNs as registered users in Oregon. LPNs 245, administrators 197, adult foster home nurses and licensees 198. And these courses, as far as the foster homes, just rolled out in June. And so we have 198 registered users. And student nurses, we love this. We have 192 registered student nurses who will then have, and everyone who's registered nurses or everyone who has registered has access to these courses in perpetuity now. So they don't have to pay a subscription. They don't have to pay anything because ODHS has said that education is important and we need to focus on nurses. Course completions, I love this. RNs in this time period have already completed 3,483 courses. I think that's pretty cool. I didn't think you needed to know the detail of all the courses, but I sure like to see that. Our significant change of condition courses are really important, and we're already seeing in regulatory outcomes for surveys that we're moving the bar as far as less citations in these areas that are really focused on nursing. The same with delegation. We're seeing that too, and we're hearing anecdotally from surveyors, from communities. In fact, I got a text from a facility regional nurse that has 10 facilities and said, we just completed our 4th deficiency-free survey. Thank you so much. Our nurses learned a lot. So this is a pretty important outcomes as we're gathering our data to look at statistically significant outcomes. But look at the student nurses. This is primarily Sumner, but some other colleges, 627 courses in a very short period. So we're pretty proud. Opportunities for OSBN, I'd like to throw that in. The nurses that OSBN may work with that may have some difficulties still in settings because there have been concerns. This could be a way that they learn how to be more successful in the environment. We can't afford to lose any nurse right now, and especially in community-based care settings. And so whatever we can do to build nurses up and help them be successful is really important. OSBN nurse employees, of course, have access to these for free. CE approval, right now we have approval as approved provider through the California Board of Registered Nurses, because that is one of the bodies that really everyone accepts around the country. And then next year, because we will have had enough time, you can't apply for the credentialing through the ANCC until you've had a certain amount of time that you can show your data. We will be applying for accreditation through there and then moving towards board certification in this specialty. So that's exciting to be able to do that. And then if the board wanted to come to our Nurse Learn conference on March 9, just to be able to talk about all the wonderful things that OSBN does in the state, you're welcome to do that. See, how's that? And for free. So that is my presentation. Do you have any questions?
Probably not a question, but I am in your statistics up there because I did, as we were talking about, I took 6 or 8 of the courses. I think it's so right to say the first year that I was in the industry and people were, because you are just one nurse in a building, and people would say, go see your administrator, go see your ED. And I went to go see both of them. And I said, hey, about these insulins and delegations. And they both looked at me like, I have no idea what to do. It is so true in that regards. And yet we allow the nurses to go in there, and it's almost like, unless you have a buddy in the system, you are wonderful for this. What I do want to actually, because we had talked a little bit about this, when we have nurses that possibly could be struggling in regards to even a disciplinary, this is free. And so if you've got a nurse directly in the community setting, I think these courses, and like I said, I've taken not because of discipline issues, but because of just knowledge, they are wonderful courses. In fact, the pain one was pretty hard for me to kind of get through. I had to reread it several times. So it is good information in a world of wealth. And so thank you for sharing that. And I know Cynthia through the years here. So thank you.
I'm curious, as the Board of Nursing is shifting now to a continuing education requirement for renewals, how you all anticipate meeting demand for that?
Well, the courses are on our own LMS system. And so we'll have that whole process to be able to show that if there is, through OSBN, a requirement for a CE, that then they have that certificate. All of that is built in right now. They have the certificate on the dashboard. They can manage their own courses and what they've completed. And if the Board of Nursing has a specific process for approving providers, then we would apply to be an approved provider and whatever those requirements were.
Be qualified, but I don't.
I want to
Just
tell you, yeah.
anticipating
I don't know
a
if
lot
that-
more demand and support you're going to need for that.
We hope so. Even we have a full tech, department, and we're constantly enhancing the courses by looking at user experience, because the courses are rigorous. They're not an easy get done with it kind of course. You can't just vacuum your house while you are listening to a course in these courses. I mean, I did some of that in my own graduate studies sometimes, but because I can't just sit down and I need to move. But the courses have a pre and post assessment, and so we're looking at those data. Our average knowledge increase is 19%. So that's a pretty good knowledge increase from a pre and post. There are interactive learning activities that you have to go through. You can't skip. Some people don't like that. And we have, and they're case scenario based. So they're full of stories and examples, and then there are resources that can be used, say for a pain assessment. And, we're using the evidence that is out there, and we have the resources to other evidence-based sites. So it's not just your voice over PowerPoint course. I guess I'm trying to say there's actually a lot of meat and expectation there. And they're not always just 1 hour either. And we have to use, as we're looking at CEs, we have to use multiple methods for determining seat time because everyone's is a little different. And we kind of go to one of the lowest denominators of some of this material is going to be hard for a lot of people, even nurses, because it's a new way of thinking. We're even teaching them how to document, how to chart, how to use SBAR, which is situation, background, response. So situation, background, assessment, response. I have to get it right. Gretchen?
I don't have a question. However, I just want to thank you for coming today. Cynthia and I have worked together in parallel and together since probably the late 1980s in various roles with various agencies and organizations. And so this has just been a boon for community-based nursing in the state of Oregon. I find myself, lots of practice questions used to come in related to RN delegation in the state. Since NurseLearn has gone in with the teaching, anecdotally, I don't have any hard concrete data, but those questions have decreased. And when the questions do come in, I mean, there will be the outlier every so often, which I will recommend that RN pursue some free education such as NurseLearn. However, the questions that are coming in are more articulate, and so you can tell people are getting a better understanding of it. And so I think that's been a real boost for the public protection point for our role here at the board. And thank goodness for NurseLearn for providing that. So thank you.
Thanks, Gretchen. We're seeing some good successes from nurses that are transitioning from acute care to community-based care. There used to be this myth that if you left acute care, you could go to a community-based care and it'd be so much easier. It's so much harder. In fact, we explain it that you take everything you've ever learned in your nursing career and you bring it to community-based care because you're using it all. And it's a very complex specialty. Thank you very much.
It looks like we have time for a little break. We need to be back here at 1 p.m. for the public forum. All right, we're now. So we're going to go. Thank you for your patience. Sorry, we're a couple minutes late to start, but we can run over to make sure everyone gets their full time for the public forum. Welcome and thank you for joining our public meeting today to share public comment. It is November 13th, 2025. The open forum will be from 1:02 to 1:32 p.m. Each person will be allotted 5 minutes. Open forum is a time for members of the public to make general observations or present items of general interest. Open forum is not an opportunity to make requests to the board or to discuss matters currently under investigation or review by the board. The board will not deliberate on any issues or requests during the open forum. The board president has the authority to stop an individual's comments if the board president determines that the comments go beyond this directive or as necessary for efficient and orderly conduct of the meeting. So we had a few people sign up ahead of time, and I understand that we have Christian Mendoza Ruvalcaba on virtually.
Yes, hello.
Thank you. Go ahead, please.
Hi, thank you, President. I have a question for clarification. If I am just understood correctly, you had said that this is not a time for a request.
Correct. This is not a time for request, nor can the board discuss due to open public meetings law. This is a time where you have 5 minutes to speak.
Thank you. Therefore, I have no further comment.
Right. Is there anyone? I think there's somebody in the room that maybe is here for public comment. Please come. Could you come up and grab a seat here? These microphones, when you press the push button, will turn green, so you know you're being recorded. And I'll ask that you introduce yourself first, and then we'll put you on the clock for 5 minutes, which is a lot of time when you're talking by yourself. Press the button. Perfect.
All right, are we on?
Yep.
For the record, my name is Christina Cowgill, and I'm a licensee, both RN and CRNA. And I appreciate the time to address Chair Cooksey, members of the board, and board staff. I am not going to be discussing the request that I have for the board, but I did want to bring and highlight this situation that I'm in, because from what I understand, other nurses and licensees have been and could potentially be in the same situation in the future. So what I'd like to speak to is that recently I've been given a determination of ineligibility to sit for the American Nurses Credentialing Center Psychiatric Mental Health Nurse Practitioner Certification Exam. This ineligibility determination cites a lacking of my core coursework, specifically advanced physiology and advanced pharmacology. So for some background, I have continuously been licensed in the state of Oregon as a registered nurse and as a CRNA since May 28th of 2008. I've held prescriptive authority in the state since 2015, shortly after statutory and regulatory changes made this accessible to CRNAs in this state. I've consistently met state-mandated continuing education for pharmacology while maintaining my national certification. My APRN license was originated in 2003 from Minnesota after a 30-month nurse anesthesia residency at the Mayo Clinic School of Health Sciences. When I decided to go back to pursue my PHMP in 2004, I went back to my alma mater, Mayo Clinic, as well as leaned on some support from your board here to clarify expectations for returning to graduate study. Because I'd already been licensed in this state as an advanced practice nurse, because you guys have already reviewed my Mayo Clinic transcripts, and in collaboration with the Mayo Clinic, I got all the archived syllabus and presented them to the university I was going to attend for my Psych MP, which was Western University. They conducted an independent review as well and determined that my education met the requirements for physiology and pharmacology. So I'm excited to say Happy Nurse Practitioners Week to everyone in the room who holds that credential. And I hope to join you. But when I went to ask to sit for my boards, the ANCC deemed that I was ineligible because they are not recognizing my pharmacology and my physiology core requirements. So I sit here 2 weeks away from graduating and serving the public here in Oregon to go back to school to take more pharmacology and more physiology. Based on page 2 of my statement, from my original education, I have 2 units of medical physiology, 2 units of medical physiology 2, pulmonary physiology and post-op credits 1, integrated anatomy, physiology, pathophysiology, and pharmacology 3 credits, anesthesia pharmacology 1 for 2 credits, and anesthesia pharmacology 2 for 2 credits. And this board has recognized my license continuously throughout my tenure in this state. I think it's an insult to nursing to have an advanced practice nurse return for an additional certification. And at this point, when I have a job offer on the line and a waiting list for people to have help with mental health in this state, that the ANCC can be allowed to, after 2 arms of their triangle, the school, the state board which license, and the certifying body is holding my ability to become a licensed Psych NP in this state up because of a technicality on the core requirements. I wanted to share that because as I've come to know this, I have now learned that other APRNs in this nation have been subject to the same ridiculous standard. And I hope that by sharing my story with the board and sharing it publicly, that we can work together to find a solution so somebody doesn't go through additional 18 months of advanced practice education to be told, oh, by the way, now you have to go back and take more education before you can work to serve your public. Thank you for your time.
Thank you for that.
Mr. President.
Appreciate.
Has requested to rescind his skip and would like to actually speak if there's still time allotted.
Yeah, I think, and don't think we have anyone else lined up currently, correct?
Signed up has just emailed that they're not able to attend.
Okay, then great. Then we will turn back to Christian Mendoza Rubalcaba, and we'll give you 5 minutes for public comment.
Thank you, President. Good afternoon, President and members of the Oregon State Board of Nursing. My name is Christian Mendoza Rubalcaba, and I am an advanced practice registered nurse residing in Medford. I want to begin by stating that the views and opinions I share are my own and do not represent those of my employer or any other entity. Although my comments are not directly related to the proposed rule changes, I would like to share an observation. Following my review of OAR 851-0550010 and OAR 851-045-0060, the phrase healthcare policy development, implementation, and evaluation appears in the standards related to RN scope of nursing practice, but it is not explicitly included in the APRN scope and standards of practice. Including this language directly in the APRN scope and standards highlights the important role that advanced practice nurses hold in developing, implementing, and evaluating health policy. This alignment also reflects national statements such as those from the American Association of Nurse Practitioners, which emphasize the professional responsibility of nurse practitioners to engage in health policy. Thank you for your continued service to the nursing profession and to the people of Oregon. Thank you.
Thank you. Thank you for the comments. Yeah, okay, so it doesn't look like we have anyone else lined up right now. We'll give a few minutes to see if someone logs on, take our time to go to the restroom, or and we'll know if anyone comes in, or prep for our afternoon. We are going to change yet again the schedule around a little bit. It's in the goal to try to finish early and to be efficient and to be thorough. But so everyone has a heads up. So after the public forum, we're going to turn to Dr. Wickenhagen and George Fox's preliminary development application. And then after that, we're going to hold the board elections. And then we will end with the delegation authority piece. So slightly different. I guess we're just inserting the elections in before. All right, so we will pivot now to Dr. Wickenhagen and the preliminary development from George Fox University.
Thank you, Board President and members of the board. This is some very exciting news today. So George Fox University submitted a preliminary development application on October 17th, seeking authorization to begin development of a DNP program preparing psychiatric mental health nurse practitioners. They have met all the requirements of this application and no deficiencies were identified. Board staff recommend approval of preliminary development status for George Fox University's proposed DNP PMHNP program, allowing the institution to continue full development and prepare submission of proposed program application for future board review. The university has been invited to attend. Dean Pam Pfeiffer is online, and April Phillips and Esther Graves are also here, and we're happy to answer any questions that you might have.
Well, thank you for making the trip out in person, as you've done before. Does the board members have, as you review your notes, any questions?
I have a question. So it says that your clinicals are synchronous telehealth clinicals?
Sorry, I was going to ask before you ask your question, if you go ahead and have a seat up front. If you're going to speak to this, then let's do it the proper way. And sorry, so we'll restart at the beginning. Just realized.
So actually, unlike many PMHNP programs now, we will be providing all clinical rotations for our students. So this will be throughout the state of Oregon.
Are they all telehealth clinicals?
No, they are not, just to clarify. So what that refers to is if a student were in a clinical situation and they're seeing a patient via telehealth, but the students will physically be present at the site.
Oh, okay. I was just going to ask you if those telehealth exceptions go away, what was your plan? But
I feel that I have a personal belief that students need to have, as entry-level practitioners, a high percentage of their clinical rotations, if not all, in person, so that they can fully assess the patient, they can gain those skills on how to do things like an AIMS assessment to look for motor movement disorders and that type of thing. I hope, did that clarify your question?
yes.
Excellent.
The only other question I have is to do with the didactic courses.
Yeah.
And they're the asynchronous format. So that means like students can take them anytime or like at their own schedule, at their own pace, or do they?
Actually, no, it's going to be more hybrid situation. Throughout the program, we'll front load the didactic coursework. So all of our students will be very well prepared and educated when they enter the clinical environment. However, they will have several in-person immersions that take place either at the beginning of each term or towards the end of the term, but they'll come to campus several times. Within the coursework, they will, while some of the coursework will be online, or the coursework will essentially be online, they will have required sessions. Well, they'll be working together as groups. For example, I've incorporated part of the program that builds upon the therapy requirement within the PMHNP program, where they will obtain certification as a Cope to Thrive provider, for example, where they'll be certified to provide brief therapeutic interventions, and that will require that they work live with other students, for example. So that will be a big part of the coursework. You're welcome.
Great, thank you so much. I
bet.
think we're ready for the motion.
Perfect. My motion is for the board to approve preliminary development status for George Fox University's Doctor of Nursing Practice Psychiatric Mental Health Nurse Practitioner Program in accordance with OAR 851-021-00101A through I, authorizing the university to proceed with program development toward full proposal submission as presented.
So moved.
Second.
It's been moved and seconded. We'll do a vote. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toabola.
Aye.
Rachel Dennis.
Aye.
Felipa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion is passed.
Thank you
Congratulations.
so much. Appreciate your service.
Okay. All right, so as we're jumping out of order, we're going to the board officer elections. As a reminder to y'all, we annually hold our board officer elections where we elect our president, our secretary, and the president-elect. We were just double checking the bylaws and confirmed that my memory is still okay. And that for any of the positions, it can only be held for 2 consecutive terms, just as a reminder, but that we do hold those elections every year. And so I think I'd like to start the discussion and nominations for the role of the board president for 2026. And just give a little, I guess, give my 2 bits of perspective in the past year of this role. As you've noticed, it's a role that I think each person is going to do a little differently, and that I'm sure each member of this board would be very capable in and provide different insights and different style into it. But as we think about who would be the best for this role in 2026, what comes to mind for me is really the president's role in setting the tone and moderating conversations and knowing when to dig deeper and when to draw in our diversity of voices, and when to realize that maybe that we can't always agree on everything. And for me, that's actually one of our goals, is to not always agree on everything. The president also has the joy of signing those final orders and stipulations, which is not too big of a task. I don't want anybody to be overly intimidated by it. And very recently, I learned of the obscure role that the president has of approving Director Prusak's PTO. So keep that in mind if you're thinking about becoming president.
Stop.
So I'd like to open the floor for nominations. People can self-nominate or nominate someone else.
President Cooksey, would you mind if I jumped in
please.
to lead this conversation and not put it all on you? Thank you. And thank you for approving my time so I could take a vacation. I'm very glad to work a few hours today, though, to be with you all for a few things. I just want to level set from what Board President Cooksey just said, but also conversations that I've had. So as we kick this off, though, I want to take a moment to acknowledge your work, President Cooksey. Your leadership has been one that's been honest and empathetic. Your unwavering advocacy for the public, for the board, for staff, for licensees and certificate holders has been commendable. Your partnership through 2025 has been invaluable, particularly in emphasizing the importance of fairness and removing biases in all the conversations that we have. And of course, especially in engaging back with alternative discipline. And even when I believed we were doing enough, your gentle encouragement pushed us all to aim higher. And so I would like to, before we go into the elections, is ask Executive Assistant Brandy Ritter to present a plaque to you, as well as invite anybody to say a few words. And then from there, I'll facilitate the nominations for those that put their name forward. So those are my words of gratitude, Marcus. It's been a great year of learning from you and with you to advocate for the board and the work that we've done. I'm sorry that I'm not there for your last meeting, but welcome anybody else to add brief words. I see the virtual hand up, so let's go with Ola Nikki.
So I don't even know if I have brief words or lots of words or just a few. It's been amazing working with our president. It was amazing. We came in together, and to see how much knowledge he brought to the team, how much patience he's had, how much growth when he took over this position from our prior board president. He has just been amazing. And every meeting, there's always something to learn from him, one way or the other. There's always something to take away. And I just wanted to know, and I think I told him this in person, that he will be very much missed a lot. And his colorful jackets are not going to be seen around.
We'll have to represent him and wear our, everyone will have to wear a colorful jacket and take turns. And then I'll let you all facilitate in the room since realize that might be challenging for me. And then I'll take it back over when you're done.
Never short on words over here. So I remember having a discussion about a year ago, I think. We were all out. I said, well, you'd be wonderful. You'd be great, Marcus. And you said, oh, no. And I do have to say, I remember that and the conversation you and I had. I'm glad that you actually decided and changed your mind on that because obviously you filled the role in a very good way. I do think being president as opposed to being just as one of the members here, there is a total respect that you have to have as well of, making sure that all of us are heard. And I noticed, different in my time here, two presidents, both good, both different. And I have to say that you have allowed the voices of us to be heard as well. So thank you.
I have so enjoyed sitting next to you this year and watching you preside over this group, and have so appreciated, as Member Stanich said, the level of respect and the safe space you have created for all of us to discuss difficult issues, not always agree, and all feel respected and heard. I'm so proud of the environment that you and Director Prusak have created for us to show up and get the work done that we've done. And so thank you.
I was going to say thank you. You've been a champion for the workforce, but you've also been a champion for public safety, and you've struck this remarkable balance that's been a privilege to watch in our disciplinary meetings. And I want to thank you for all the respectful communication that you've had with the investigative staff as well when we have facilitated more difficult conversations. So thank you, and thank you for all the learning.
I'll be brief because brevity is a lost art, but I've told you before, I think you've been a fantastic president. You just stood up to the role. And as others have said, you just allowed a safe space. Everyone has a voice. You're always looking around to make sure everyone is heard. And I think that's super important. So thank you for all of the things you've done for public protection and for being our president. Appreciate it. You'll be missed.
I'll just real quick say, because everybody else said most of what I was going to say, but I just also appreciate this deep well of experience that you bring into this. And I agree with everyone else, creating this space where we could really discuss difficult topics and it not be, created a space where you could just talk and things weren't taken personally, and we could really share where we were coming from. And you ask great questions. So you're going to be deeply missed.
Thank you all for such kind words. I hate being the center of attention, so if you can't tell, but I think each of you know the respect I have for you individuals as well, and for all the work that you do.
Thank you, President, for letting me put you in the center. You deserve the plaque and the words of gratitude. But it's been an honor to work with you and walk step by step with you the last year. And on to that, we can move into the elections. And so just as a reminder, ORS 678 .150 sub 1 states that we elect annually from its number as a president, a president-elect, and a secretary. And the reason why we do it on this meeting is that it also states that the regular election must occur on the second day of regularly scheduled board meeting, and November is the only board meeting that has a 2-day meeting before January 1st. So the election's happening today, and the officers elected will begin their term on January 1st. And I sent an email directing those interested in running for positions to present their interest here. And I wanted to share that if we have more than one candidate for a position, the board secretary will conduct a roll call election where the secretary calls the roll and each board member will state the name of the candidate they're voting for. So this is how we will be leading the election. And on that, we'll start with the president election, and I invite board members interested to raise their hand, to put their name forward, and I'll call on you to speak to the election. And I will have someone in the room share if anybody in the room has raised their hand, since I cannot see that.
President-elect Hill raised her hand and no one else. And then Oleniki.
Great. Okay. So why don't we have Oleniki go ahead and present your intent first virtually, and then we'll go into the room for board member Hill.
Thank you all. Thank you to the board for this opportunity to run for this office. I thought about writing a nice speech, but for some reason I can't come up with a great speech. So I said I would just speak from my heart. Running for this position is, it has been on my mind. I thought about it a lot. I talked to my family. I think I talked to Marcus also about this. And it's on my mind because I have to look at what my personal views and personal values are. And what my personal values are being fair, equal representation, and actually just being open with everyone. And I think being in this role as a board president would afford me the opportunity to kind of step into the huge shoes that our current president is leaving, which I might not be able to fill, but I would kind of make pattern to make the shoe fit at some point in time, to ensure fairness and ensure equity, ensure we're all being heard, and we're continuing to advocate for public safety.
Thank you, Board Member Tolbola. And we can turn to elect Hill.
It has been, I tried to write a speech. We'll see how I do with that. It has been such an honor to serve on this board and to serve as your president-elect. I would love the opportunity to serve as your president. When I was preparing for today, I thought about the speech that I wrote about what makes a good member for the NCSBN annual meeting, and that was a long speech, so I'm not going to share that with you. But I wanted to share just a tiny little bit. What I bring is an outsider's perspective, a passion for public protection, and a commitment to active listening and lifelong learning. And so similar, I want to create that same safe space. I am so proud of the work this board has done since I joined it in 2023. I'm proud of our thoughtful and respectful discussions. I greatly appreciate our awareness of the systemic issues in the workplace that put nurses at risk for disciplinary actions, and that we as a board can help clarify nursing responsibilities, scope of practice, professional expectations. This, serving on this regulatory board has been just a wonderful way for me to use my professional and personal experience and values, and ensure that my community is a safer place. And I would love the opportunity to follow in Marcus's footsteps and to try to, to continue, because those footsteps are huge, but to try to continue to create that that same safe place where we have the wonderful dialogue we have and the respect and, get to preside over these in such a, I've been carefully monitoring you all year long, and I would just love the opportunity to, try to utilize some of the skills that I've learned from you. So thank you.
And so what we'll need now is for our secretary to do a roll call for the president and for each member to share the vote. And if there is a majority vote, we will have our president. And if not, there'll have to be a discussion.
Okay, and just point of clarification, everyone votes.
Yeah.
Okay.
Everyone.
Marcus Cooksey,
Toabola.
Margaret Hill, Claire McKinley Yoder, Toabola, Joni Callis,
Toabola.
Linda Stanich,
Tolabola.
Oleniki Toabola,
Toabola.
Rachel Dennis,
Tolabola.
Felipa Nesta,
Toabola.
Rachel Mitzel.
Hill.
Am I announcing? Toabola has won the president role.
Congratulations. And thank you all for participating in that vote. I think we have shown we are a board that has stepped up to challenge each other and what we're doing. So thank you. And now what we will do is move on to the election for president-elect. And of course, as you know, somebody filling that role can fill it for 2 terms in a row, 2 years in a row of 1 year each. So for anyone who would like to put their name forward for that, please raise your hand to give your intent, or I guess I can pass this over to someone in the room to see the hands raised. I hope that's President-elect Hill agreeing
Yes.
to run again, because I hope you know that everyone here appreciates all of the work that you do on the board.
All right, so I think we can hold a formal vote.
Okay. Marcus Cooksey,
Hill.
Margaret Hill,
Hill.
Claire McKinley Yoder, Hill, Joni Callis,
Hill.
Linda Stanich,
Hill.
Oleniki Toabola,
Hill.
Rachel Dennis,
Hill.
Felipa Nesta,
Hill.
Rachel Mitzel.
Hill.
Margaret Hill has been elected to president-elect.
Fantastic. I look forward to continuing in that role and being the voice of the president-elect, working alongside board member Tolabola. And lastly, I would love for anyone to show their intent on being elected as secretary. And again, pass it over to you in the room.
I'm happy to put myself forward for a second term. Would anyone else like to? Would anyone else? I'm really open to someone else being interested. All right, we'll do a vote. Marcus Cooksey,
McKinley Yoder.
Margaret Hill,
McKinley Yoder.
McKinley Yoder, Joni Callis,
McKinley Yoder.
Linda Stanich,
McKinley Yoder.
Oleniki Toabola,
McKinley Yoder.
Rachel Dennis,
McKinley Yoder.
Felipa Nesta,
McKinley Yoder.
Rachel Mitzel. All right, I have been elected to secretary for a second term. So next year, someone else's opportunity.
Well, congratulations to all that have served in all of 2025 and moving into 2026. I look forward to the work ahead. And once again, on behalf of all of the staff, the investigation staff, as investigation manager Erin said, your thoughtful discussions all year long as president. So thank you again. And on that, I'll conclude the conversation around board elections. And I will let you know that I have delegated the delegation authority. Thank you, Marcus. To investigation manager Ferris, who fully understands the work that we've been doing to get there. And I know there's a addendum sent to you all. I think in my original memo, I was over-explaining the work that we've done and to do, given the questions from the last board meeting. But I know that it's been revamped and reworked for clarity, and know that you will all have a great discussion. So thank you all for letting me join virtually for a few of the items on the agenda today.
I know this seems odd at the timing of it. Would the board like a few minutes to take a break and review the updated memo before we enter into the discussion?
When so the updated memo you're mentioning is we have printed only, right?
Yes, printed only. I distributed it earlier this morning.
Delegation authority dated to today. Yep.
And this goes down to 2 motions
Yes.
instead of the.
And then
Yes, and we can talk about that in discussion. Would the group like some time to take a break and read them?
Till 2 o'clock, 2:05?
I have extra copies.
So break until 2:05.
2:05. Okay, break until 2:05. We'll come back to Investigations Manager Ferris and Line Specialist Bloomquist, you're here, I guess. Expert witness, I think. Do you want to speak a little bit to the removal, continue this discussion that we had back in September, and why we would want to remove some of these motions, and then why we're at with the other two that we're looking for a vote on?
All of the things. Absolutely, Board President, members of the board, thank you so much. I was invited to speak on behalf of Director Prusak. I will aspire to being as eloquent as she is. I've also invited Compliance Specialist Bloomquist to join me, as the two motions we'll be asking you for this afternoon are related to compliance work and stipulated orders for probation. You did receive a version of the memo in the packet on page 675. I did distribute an updated memo earlier this morning for your review prior to this conversation. The updated memo is an attempt to clarify the language and simplify what we're asking you for today. It did ponder some things in the previous memo, and I'm upsetting how I originally arranged this conversation for you. The previous memo did discuss some things that are already established in rule, such as the first couple bullet points, talking about, well, it's actually the third bullet point where it talks about the second and third bullet point, or second and fourth bullet point, excuse me, where it talks about signature authority. Signature authority is already established in Division 1, so we don't require a motion for those. In regard to the first bullet point and clarifying around the civil penalty, we aren't taking a motion for the civil penalty for two reasons. One, taking that motion could potentially complicate one of the delegated authorities that you did grant board staff in September around finalizing default final orders. I just want to clarify for the board that staff here at the board are not imposing civil penalties without board awareness and board vote. So at the point that we are taking a default final order, the board has already reviewed the circumstances, took a vote to issue a notice for that civil penalty. We would just be finalizing that civil penalty. So again, board staff is not imposing civil penalty without board review and vote. Just that clarification. An additional clarification on the third bullet point in the previous memo. There's some confusing language there. What we wanted to make clear is that our education policy analyst is not imposing civil penalties, but instead, if during the course of a survey is identifying potential MPA violations that would warrant additional review, is making sure that information is forwarded to the investigations department, at which point we would investigate and then put in front of the board for review and vote. So hopefully that makes some clarification. Hence why the new version of the memo is much shorter and only asks for two additional motions. And I'll take a deep breath and I'll make sure that I was clear on anything if there's any questions about some of that. And I could read the new memo out loud if that would be beneficial to the board. Okay.
I think we had the time to review it. Thank you. First off, were there any questions then, or anything you wanted to sew up from the removal of those four, or any of the other board members? I think, Manager Ferris' explanation was clear, and thank you for that. And then, if we move to the other two pieces related to compliance and probation, do we have any questions as we look over that and draw?
I don't have a question, but I'd like to make a comment that I really appreciated that the clarity in these asks. I think it's much easier to read and understand than when we previously looked at it in
September. Thank you.
Thank you very much for your work on that.
No, thank you for that feedback.
Yeah, no, I think we've all seen in our time here that these would have been great to have for public protection as well as the participants.
Yeah, I actually, thank you for getting those moved aside, because I had a lot of confusion about these, but sticking to just the piece of paper. The first one I think I have an understanding of because we actually had a case yesterday. And so I appreciated your input at that. So I think I got the first bullet point. Can you maybe provide an example or two of how the second bullet point would work, how that would be implemented? What does that look like?
Yeah, I'm going to let compliance specialist Bloomquist take that.
It's actually something we've been doing for a while, but we realized that the CAC does not, delegation can't be placed with a committee. It has to be with an individual. So we brought this back. So how it worked in the past was, as you know, in our older stipulations, people had 36 months to complete 24 months of monitored practice. Some of our nurses, it takes them more than that first year to get a job. And so if there's no compliance issues, all we're doing is just giving them a little bit more time to finish that 24 months of monitored practice. That's all the amended STIP was doing.
An attempt to prevent potential additional disciplinary actions from occurring, quite frankly.
And just to clarify too, so you're saying that they're having some difficulty even getting employment, and so that's sometimes why it takes so long?
I will say we're doing those fewer now. Occasionally we do have the person that just takes a while. Sometimes it depends on the area of the state. But I haven't actually done one of those for a while, but it does happen where somebody just takes a while to get there.
Thank you.
I just wanted to clarify, for both of these, it would only be like a one-time thing. So like if there was compliance issues at the end of a probation, then you could have another 6 months, but it's not going to end up being another 6 months and another 6 months and another 6 months.
Yeah, in practice, that's correct, Member Dennis. I think at the point we see something happen repeatedly or a pattern of events, we would definitely bring that to the board for the board to decide the next action for public safety.
Great. Looks like we're ready for the motion.
Great. So I have two separate motions. I make a motion, the board approves to delegate to the executive director and the investigation manager the authority to amend stipulated orders for probation to extend probation for up to 6 months if relapse occurs within 6 months of probation completion date.
So moved.
Second.
And moved and seconded. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toobola.
Aye.
Rachel Dennis.
Aye.
Felipa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion is passed.
I make a motion that the board approves to delegate to the executive director and investigation manager the authority to amend stipulated orders for probation to extend probation up to 12 months when a participant needs additional time to complete monitored practice and there are no demonstrable compliance concerns.
So moved.
Second.
Been moved and seconded. Marcus Cooksey.
Aye.
Margaret Hill.
Aye.
Claire McKinley Yoder. Aye. Joni Callis.
Aye.
Linda Stanich.
Aye.
Oleniki Toobola.
Aye.
Rachel Dennis.
Aye.
Felipa Nesta.
Aye.
Rachel Mitzel.
Aye.
The motion is passed.
Thank you.
Is that right? That's it, right? The meeting is adjourned at 14:14.
Wow.